Welcome to the Oregon Health Policy Board meeting. We'll give it one more minute to let any other folks join us. So we'll get started here fairly soon. All right. Okay, I think we'll go ahead and get started. Good morning, everyone. I hope you're all doing well. Welcome to the May Oregon Health Policy Board meeting. We'll go ahead and get started by having Tara go over some of our regular housekeeping items, and then Steph Jaron will do a roll call for us.
Great. Thank you, Oscar, and thank you for facilitating and hosting today while Chair Banksburg is not able to join us. So thank you, Oscar. Just a couple housekeeping items for everyone. I want to let you know that today's meeting is being recorded, and the recording will be available on the Oregon Health Policy Board's website for reference later today or tomorrow. And also during today's meeting, there is closed captioning available. So if you'd like to display live closed captioning, simply click on the closed caption button at the bottom of your screen. And I just like to ask people to please update your Zoom name for your first and last name so we know who's joining us. Also, we ask that if it's accessible and comfortable for members to share their video. However, we know Zoom fatigue has set in, and so please feel free to turn off your video as needed, to stand, stretch, do whatever you need to do to take care of yourselves. And just so the members are aware, Ebony is having a little bit of technical difficulties this morning, so she is available on the phone, but she's not able to show her video. And also, if you have any questions or issues, feel free to chat the host, myself, Michelle, or Daphne, but the chat feature is turned off for all other participants. That's all I have for housekeeping. Steph, go ahead with roll call.
Oscar Arana.
Here.
Brenda Johnson.
Here.
Sorry, I went out of order. Ebony Clark.
Here.
Kirsten Isaacson.
Here.
Santa.
Here.
Great. And David Bangsberg is out for today's meeting, as has been mentioned. Thanks.
Thank you, Tara, and thank you, Steph. So my name is Oscar Arana, and I am the Vice Chair of the Oregon Health Policy Board, and I am stepping in to cover for David while he is on a well-deserved vacation. So I'm really excited to be able to start the meeting by sharing some really excellent news today. I'm excited to announce that we have 2 new board members who will be joining us next month. The 2 new board members are Jessica Gomez and Bill Cramer. Jessica Gomez is a small business owner in Southern Oregon. She mentors young women and people of color interested in STEM careers. She was named Executive of the Year in 2020 by the Portland Business Journal. Jessica believes that improving access to healthcare while reducing the cost of care is of the utmost importance. She's excited to help create a sustainable and equitable healthcare system that we can all be proud of. Bill Cramer is a nationally recognized expert in health policy, finance, and economics. Bill has devoted his career to improving the quality and affordability of healthcare for everyone and looks forward to helping the board with its priority work. Bill offers extensive experience and expertise in health policy, quality measurement, value-based provider payment, health insurance, healthcare finance, and reducing the total cost of care. Also, not new to the board, but staying with us a little bit longer is Chair David Bingsberg, who was recommended by the governor to serve another term on the board. We are just delighted to have more time with David, who has been a committed and a dedicated board member since he's joined us. So this is all really wonderful news. I'm excited to have all this great new talent joining the group and the board. So it's really great to be able to share some positive news during, some challenging times that we've been facing during this critical work. So a really high level review of our agenda today. We're gonna cover the following presentations and discussions. We're gonna have an update from Director Allen. We'll also hear from the OHA Government Affairs team. That'll be followed by public comment, and then we'll get an update regarding the progress of the Medicaid waiver. And we'll close things out with a discussion on work being done connected to a new early learning metric. So, but before we can get to our agenda, our first order of business this morning is to vote on the draft April meeting minutes. And a copy of those minutes was provided to each board member and is also posted on the Oregon Health Policy Board website. Is there a motion to approve the April meeting minutes?
This is Brenda. I'll move approval.
This is Ebony. I second.
Okay, thank you both. All those in favor say aye.
Aye.
Aye. Anybody opposed? All right, the April meeting minutes have been adopted.
Hey, Oscar, can I just clarify one thing just so folks know? So the Jessica and Bill and David too, they still have to go through Senate confirmation that's scheduled for next week, but it's been, the governor's made the appointments, and if all things go smoothly next week, then hopefully we'll have those folks at the next board meeting in June.
Thank you, Jeremy. Yes, we will hope for confirmation, and hopefully they will be able to start joining us as early as June. Okay, so Director Allen is here this morning to provide updates on Oregon's COVID-19 response, recovery and vaccination efforts. Also, David Baden, I believe, is here, who is OHA's CFO, and he's going to provide information on the American Rescue Plan Act and its impacts and considerations for Oregon. All of those meeting materials are included in your packet. So Director Allen, we'll let you take it away.
Great, thanks, Vice Chair Arana. Dave and I are going to try to split a bunch of stuff up between us in about 20 minutes, so about 10 minutes or so each. And as usually is the case, I have to leave at 9 for the Governor's Medical Advisory Panel, but I'll be back after that for the rest of the meeting. So a few things to cover in my portion. We've got some signals beginning to occur that it looks like cases are beginning to flatten out. Which is good. This is a similar pattern to the B117 driven spikes that we've seen in places like Minnesota, Michigan, Washington. We maybe are a week or so later. And I think what we find in all these cases is it's a combination of public health steps that are being taken, plus what happens when you're about to take those steps is we spent a lot of time in the news over the last couple of weeks talking about hospitalizations being up and those kinds of things. And so if you think of Peter Graven at OHSU's a cycle of fear and fatigue, people begin to flip over from fatigue into fear and start behaving differently, even ahead of those public health measures. The public health measures, though, are still important to take because it's what really gets us from plateauing into driving the cases back down again. It's also encouraging that first of all, the case numbers never went and sailed through 1,000 cases. Back in the winter, we didn't even have a speed bump at 1,000 cases, and it ran up to 1,100 a day on a weekly average. And so we're doing better this time, which is very encouraging. Test positivity on a weekly basis seems to have peaked out around in the 6 point something % range, rather than sailing on past it to 8 or 10%. As it did during the previous peak, and so that's also encouraging. A little too soon to tell on hospitalizations where we are on that, because of course that lags that lags behind cases by a good week to 10 days. The one thing that's consistently true, though, is that our fatalities during this spike appear to be much more modest. One of the things I checked in with, a big element of the coronavirus response and recovery units work is supporting long-term care facilities through outbreaks. And that's a joint effort between us and ODHS that involves healthcare-acquired infection strike teams, staffing assistance, decompression units to move COVID-positive patients to other facilities, all those kinds of things. And the demand for that work this time is much, much, much lower. The number of outbreaks that are having that level of impact in long-term care is much smaller, which of course you would expect to see with the push on vaccinations in that population going clear back to December. But that's really good to see. In terms of vaccinations, a few things. Our demand has declined a little bit, but not so much to be alarming yet, although there's some geographic disparity where I am alarmed. We're down around 33,000 doses per day on a 7-day rolling average. We peaked out a little bit over 40,000 when we were getting the maximum amount of Johnson & Johnson doses administered. Those are beginning to come back, but they've not come back to the level that they were before, and then demand elsewhere is also lagging. Finally, for the very first week, Portland metro area is sort of doing normal scheduling where you can go onto a website and find an appointment and sign up for it, versus the lottery. We have, as you maybe saw in the news over the weekend, we've now exhausted all the names in the Portland metro area that were signed up to go into a lottery and be invited to schedule vaccinations. Convention Center now is moving to being supportive of our 16 to 18-year-old strategy, which is limited to Pfizer, as you know. And they've been working with educational service districts in the Portland metro area to enlist schools to help with transportation and scheduling, and basically getting kids down to the convention center who are eligible and want to be vaccinated, obviously, to work on beginning to get our vaccination rate up in that population. If you sum it all up and look across the state, we're at about 30% fully vaccinated, another 12% or so in process. And the trend lines are still going up pretty steadily in those categories, even amongst the very oldest seniors. We haven't topped out. We're still adding 1, 2, 0.3% in each age category every day, and so the demand is slow, but it continues to be there, which is encouraging. Across the state, we range the highest county of vaccination for either full or in process is Benton County. 3 counties are over 50%, Benton, Lincoln, and Hood River counties. And we got a couple of counties that are down in the 20s. Umatilla County at 24%, Mount Here County at 25%, Lake County at 26%. And these are amongst the counties that have basically at some point, not permanently, but for the moment, said, don't send more vaccine. We can't use it right now. I'll come back to that in a second, because the thing I want to finish up with is equity, where we've made some really strong progress in the past month. If you went back to April 1st, you would see that the Latina population was getting vaccinated at about 40% the rate of the overall statewide average. I don't have the numbers right in front of me, but I want to say it was about 15% versus 27%. 4 weeks later, after a bunch of strategies that we've been investing in over that period of time, the Latina population is now up over 50% of the statewide average vaccination rate, and that gap is closing by a fairly healthy amount each day. For the African American population, we're closing in on a 2/3 vaccination rate. That's also up over the month. The Native Hawaiian Pacific Islander population is over 100%. Their vaccination rate is higher than the overall statewide average. And so I think the strategies that we've been talking with you about for a while around focusing on FQHCs, mobile vaccination opportunities, migrant seasonal farm worker strategies at work sites, those kinds of things are really beginning to chew into this gap. And now we're working with the Hispanic Health Coalition to basically add new strategies and accelerate the strategies that we're using. So after a couple of months of feeling really frustrated that we felt like we were, doing things that we needed to do, and kind of like in the cartoons, our feet were moving fast, but we weren't getting anywhere. We're really now showing some meaningful progress, and I'm really happy with that 40 to 50% increase over the course of April, and that appears to be accelerating. That gets me then back to Umatilla and Malheur counties that are on the low end of vaccination. That's been a focus of a FEMA mobile clinic that we've had operating now for, Dave, I think it's been the better part of a month that they've been on the ground there.
Between there and it sort of started in Morrow and has been moving around and now is actually heading to Columbia County. It's there right now.
Yeah, so focusing on areas that are A, low vaccination uptake areas, and B, sites where we've got equity issues about vaccine distribution and the ability to work with local partners to focus people into those settings. So that's basically everything that I've got. Vice Chair Arana, do you want to take questions now, or you want to have Dave go and then have us both take questions?
Let's go see if there's any questions for Director Allen before we move into Dave. Brenda.
Just a quick question. Thank you, Director Allen. It's always really helpful to hear that we're making progress. I'm curious if you can speak to the conversation about vaccine eligibility for kids ages 12 through 15, 16, as that news emerges.
Yeah, we're anticipating anticipating that to come out from FDA this week, probably. It introduces, basically we take our existing strategy of how to widen the geographic availability of Pfizer, which is usually some kind of a hub and spoke sort of a model, because we've got hubs in enough places in the state that we can get Pfizer most places around an organized effort. 12 to 15-year-olds adds an additional complication though around parental consent and how to manage the paperwork around that. And I've been out for a couple of days. Dave, do you know more about that element of this than I do?
No, I think we haven't seen exactly when the FDA and sort of the FDA's final step and the CDC's ACIP have been scheduled. It's a little unclear of if it's a different set of steps, because all it is adding ages to a currently sort of EUA vaccine. So it may be a little quicker, but to Pat's point, I think it's this week. It looks like we're just hearing news out of the White House is that because there are a whole bunch of states that did not order their full dose allocation, that there likely is more doses for Oregon to order, which will be really good timing to get a lot of Pfizer into the state for that starting next week potentially, because the extra challenge is pediatricians obviously have not been a natural spot where COVID vaccines would have gone, and now it will be a natural spot that will need a lot of COVID vaccines, and it's Pfizer with ultra cold storage. So if only that last piece wouldn't be there, it'd be a heck of a lot easier to do this.
Yeah, the good news is the logistical lift doesn't change by going to 12-year-olds, but as Dave indicated, by moving into pediatricians, not only do you get the kid, but you've got a shot at getting the family as well. So that's also an important opportunity.
John.
Yeah, of course, in my demographic now, the biggest question is when should we travel out of the country? I look at the CDC side, and it's not encouraging. And I tell some of my, 70-year-old friends, be careful, that the world is not in great shape. And I think to the degree that you all at some point want to start addressing your take on that, you might think about that and how to evaluate international travel.
Yeah, that's a great point, because as you allude to, it's really a combination of how well vaccinated are other parts of the world and how much data emerges about the true effectiveness of the vaccine, which is actually a bright spot, because unlike most cases where you get real world data and it turns out to be not as rosy as the lab data, this appears to be proving to be more effective than thought, even at preliminary stages. So, but those are, I think, the two factors we need to keep an eye on. Don't go to India.
Does anybody else have any other questions for Director Allen?
This is Ebony. I just want to thank you, Director Allen, to you and your team just for your quick responsiveness around kind of, using the priority around the equity strategy and working to continue to, hear the voice of the communities and then in real time adjusting priority and strategy. And there's a lot of need, a lot of competing and equally weighted priorities. And again, I just want to thank you and your team for just y'all's quick responsiveness. So thanks.
Thanks, I appreciate that.
Director Allen, I was curious if you could sort of talk a little bit about the strategies as we get into this sort of like next phase of vaccinations where, I think that the supply is going to be larger than the demand. And what is OHA sort of like thinking about implementing to get folks who are less likely to want to get vaccinated?
Yeah, thanks, Vice Chair Arana. I would say if I were to try to sort of sum it up at the highest level, it's to get us increasingly out of the mass vaccination site business and get those doses redeployed to primary care providers, because we think that's actually the best messenger that someone should get a vaccine is the person that they get their care from, day in and day out. And so the more vaccine we can get in those locations, we think the better a shot we'll have. And then also be able to use doses in much more tailored fashions around faith-based organizations, community-based organizations, other trusted voices, where we can set up, not so much a mass vac site as a pop-up kind of an event, which we've already now had some really good success with. We had some great success around migrant seasonal farm workers at work sites, and that's a population particularly that is not a one-time opportunity. It's a kind of an opportunity throughout the entire summer and into fall that we can continue to work with. And so the strategy needs to get a lot more tailored and a lot more local. And once we get out of mass vaccination sites that are using tens of thousands of doses a week, we can redeploy those doses in ways that get them to a lot closer to people in the hands of or close to voices that they are more likely to trust. Now, all that said, we're still going to have some challenges because if we just go back and sort of do it like we do influenza, we don't do a good job in all those populations with influenza either. And so we really do need to think about how we get vaccine distributed locally, but then communicate differently with populations. And that's a lot of the work we're doing right now with a variety of organizations across the state in different communities.
Thank you. Thank you, Director Allen. Is there any other questions for Director Allen? All right, Dave, let's hear about the American Rescue Plan Act.
Awesome, thanks, Vice Chair. I think there are some slides. I'll look at that, like magic. All right, so yeah, I'll provide sort of what we know so far, and I will say that there still is a lot of guidance forthcoming from the federal government. I think it seems that this is some flavor of the CARES Act Part 2 of things that happened last year, the coronavirus relief funds, which was a huge part of our pandemic response, how we funded a lot of the core work. But we haven't received all of the guidance from the Treasury Department yet. So I'm going to go through sort of a medium high level of where things are at, and happy to answer any questions. So next slide. Again, talk about purpose and funding. There are some specific Medicaid provisions that were added, and then talk a little bit about Oregon. We being OHA have put together some thoughts for the legislature on how to maybe think big on some investments, should there be an appetite to think big in doing some of these one-time investment actions. And so we'll talk a little bit about that, and happy to answer questions. Next slide. So here's broadly, whoop, back one. One more after that. All right, got it. So again, broadly, the American Rescue Plan Act, this is emergency supplemental funding. So this is not ongoing core money. However, there's a lot of I would say some sort of juxtaposition in the bill itself about asking for extending or thinking through long-term things with one-time money. Now, I will say, having worked and done at the CDC for a long time in budget work on the public health side, this is both a blessing and a curse for the federal government, because I mean, I will say on the public health side, I mean, basically CDC is going to get probably 4 or 5 times its annual budget in one-time money. So I mean, like a huge amount of investment in the public health system. However, it is one-time money, with a hope that some of this obviously would continue. But that's a 2022-2023 budget issue that this will set up potential cliffs of money. And I think the biggest piece is around workforce. You know, when we're saying bolstering the public health workforce, that would imply a long-term investment. You can't triple the number of public health nurses that we have in the state, and then all of a sudden 3 years from now say, sorry, no more money. We can't do this anymore. So this is going to be, I think, some of the challenges on all of this money of how to do big one-time improvements that then have some potential tails to them. Next slide. So this is not Oregon specific. This is broadly the main sort of pots of money that are a little bit more public health centric. In addition to this, I'll get to the piece that is coming into the state as well. So that state and local fiscal recovery, that is sort of built into this guidance that we're going to get from the Treasury Department about money coming to the states for for continued continued response, revenue replacement, etc. Uh-oh, did I look like I froze for a second? Sorry. So Oregon's estimated allocation from that is about $2.6 billion. In addition, there's a lot of money that is also going to local government as well. So this, again, allows for a lot more freedom and flexibility in this biennium's budget for the legislature and others to think through how they're going to invest money in general fund, knowing that this is coming as well. Again, this amount of money coming through CDC on testing, tracing, and mitigation, public health workforce, vaccines, and therapeutics, to put in context, CDC's annual budget is usually about 12 or 13 billion. So you can see how much more dollars that is to support sort of this type of work. Next slide. So just quickly on some Medicaid provisions here. Some of these start next April. So in 2022 on some modifications for pregnant and postpartum women, as well as the state option to provide qualifying community-based mobile crisis intervention services. We still are, have some research and work to do on this. There was a lot of extension of 100% federal match on a variety of things. So here is American Indian Alaska Native at NARA of paying that fully with federal funds. So that's obviously good news and helps save state general fund. Next slide. I won't go through all of the words on this page. Again, sort of some additional increasing HCBS FMAP rates. But then again, during the declared public health emergency, a lot of expanded resources for sort of hospital payments, as well as others. Again, allows for a lot more reimbursement and not having to hit state funds as much. We're still digging through sort of exactly what all of this means from a fiscal perspective between state funds and federal funds. But, again, while this public health emergency is going on with, sort of 100% FMAP for paying for coronavirus testing and vaccine related work is helpful. So a lot of additional money and some new provisions on the Medicaid side. Next slide. And next slide. So as we were thinking through, again, with a somewhat flexible pot coming to the state, this 2.6 billion plus additional money coming to local governments, what would be an opportunity to think big and to support our 2030 strategic goal to end health inequities in Oregon, support the state health improvement plan, continue to bolster and support health equity money. Obviously, the money and system and support for the behavioral health system, thinking through other things with big one-time infusions of money where we could make a big difference. Next slide. So what we put together for sharing with the legislature and the governor's office is all this adds up to about $2.5 billion. So OHA would be happy to spend the entire amount of money that the state is getting and have some good ideas to do it. I don't think that will likely happen, but we did want to throw out some big ideas. $1 billion investment in behavioral health infrastructure and workforce. I think as this group and others have talked extensively about the systemic challenges in the behavioral health field on bricks and mortar, from not having enough beds to obviously the workforce and other capacity. You could see a large half of that being facility infrastructure costs. The next one on a Healthy Communities grant, this is one that we're actually working in partnership with the Oregon Department of Human Services and the Oregon Department of Education to think through really a new way of looking at sort of a Healthy Communities grant that looks at upstream social determinants of health, but then also thinks through all of the wraparound social and community supports, from childcare to obviously behavioral and other support at a very targeted way. So providing potentially a larger amount of money than a normal health community grant. I mean, we were thinking of sort of $50 million for 10 communities. So a very large investment to think through how to create both potentially at a neighborhood level in Portland, but even to a county level in other places, this work, and have a good partnership with ODHS and ODE to do this. And then clearly on sort of the increasing access to healthcare equity side, really moving forward with trying to fully fund health equity work, both within OHA, support healthcare infrastructure on Real D implementation and collection, continue some work with Ccos on equity grants going forward. And then last but not least on here is technology modernization. This is, if this is really all of the underlying technology at OHA, supporting whether it's Medicaid, behavioral health, public health. All of the systems in some cases are very, very old. I think our last COBOL programmer is 127 years old, to be able to help back up some of the work that we have. And so this is definitely an overdue investment, and truly would be sort of a big one-time push for a technology modernization. Next slide. So one other piece that's coming in the ARPA money is support for health centers. So community health centers, you could see $84 million to support 30 health centers around the state. That was another big piece of the ARPA dollars, is direct money for health centers, federally qualified health centers around the state. So again, there is lots and lots of dollars coming in a variety of ways to the state. You know, more to come on how flexible this will be and what will actually, you know, things will look like going forward. But happy to take questions. I think that was my last slide. Yeah, happy to take any questions.
Thank you, Dave. Any questions from board members? Brenda?
Dave, thank you so much for this presentation. It's very helpful, and I'm really recognizing the power of your statement of, while these are one-time infrastructure resources, what we end up doing in 22 and 23, you know, and the impact of that. Are you contemplating how to position this opportunity so that the impact of the reduction, in essence, what will feel like a reduction of funds into the future, isn't quite so intense?
Yeah, so I mean, so Brenda, yes, but I don't think we've gotten far enough along to know exactly all the streams and what OHA will be receiving. So for example, on the, you know, the public health side, there have been some of this money that has, you know, now we know what we're going to get in Oregon, but not all of it. There's some longer timeframes for CDC to develop some funding opportunity announcements to us. But your point is super well taken, and I think we've had a lot of internal discussions of, you know, how to think about, you know, expanding the public health workforce that doesn't create these, you know, these big, you know, cliffs that we get to in the future. You know, I'll say on the CDC side, they're excited and really worried of what this will mean. And I know, you know, we've been on discussions with a lot of the other state health officers of how to think through this in that sustainable way. You know, because I ideally is that, and some of this money also does not have a, you know, like it's know your funding. So basically you have CDC has as long as possible until Congress takes it away to actually obligate money on their end. So they may take a little longer than they've done on some of these past supplementals to get money out, which then allows us a little bit more time to plan so that these, you know, these cliffs are not as dramatic, but it is definitely a risk.
Okay. Thanks, Dave.
Other questions? Kirsten.
Thank you. Thanks, Dave. This is a fascinating presentation, and kudos to those rising to the excitement and challenge here of what these funds mean. So thank you to all that great work and work to come. I was curious with the pretty large bucket allocated to technology modernization, if any of that will offset some of the cuts of the work. It seems like some of High-Tox work has been pulled back because of other funding restrictions shifting or changing, not quite a cliff, but some pullback of other funds. And so, yeah, does any of this work, does any of High-Tox work fit into this bucket? I was sad to see the provider directory go.
Yeah, I mean, I think it definitely could fit in that bucket. I think just to what those buckets are, I will say that this is a proposal in its, well, I would say its earliest stages, but a proposal. And it's a proposal, honestly, with, I'm not sure exactly what home the proposal is going for. So I'll be honest, this was an opportunity that OHA wanted. We were asked by the legislature, it was kind of a fun ask. We were asked, what would make OHA awesome? And so we put together a very large proposal that Holly Heiberg and I and a few others put together to what would it take to make OHA awesome. I I think there's an appetite to try to help make OHA a little more awesome, but I don't know if there's an appetite to make us $2.6 billion more awesome. So, so my very long answer, Kirsten, to your question is, yes, I think there's a lot of different opportunities of general fund, federal fund swaps that could be useful. And we're working with the legislature on a lot of those, even for this next biennium's budget, to see where things end up. Just make OHA awesome. That's our goal.
It's a good motto. Do you, Ebony, did you have your hand raised?
Yeah. Yeah. And, you know, and I don't know if this is more of a question or just kind of me thinking out loud. But, you know, I think that, you know, to me, it's important to think about, so I'm thinking about the realm of public health modernization and thinking about, you know, quite frankly, how over the course of the last, decade, there's limited resource. So, you know, we have to prioritize, you know, what can be funded. And I think over the last decade, you know, we all, which has been intensified by COVID-19, can see the effect of what happens when you have an under-resourced system. And so when I think about public health modernization and, you know, being able to sustain the funding for kind of minimal thresholds, you know, my question is, you know, as we think about the state budget and state general funds versus the ARPA funds, you know, what are kind of the thoughts or strategies there? Just, you know, because to me, I think about how do we have sustained funding so we don't have this constant kind of yo-yo effect within our system, because I think, again, we're seeing the effects of what happens when you have an under-resourced system. And to me, there's, you know, just the general kind of threshold around basic current service need versus getting to these places of aspirational innovation and awesomeness and things like that. So not sure if that's really a question, a statement, just what I'm thinking about as I'm taking this all in.
Yeah, Ebony, it's whether it's a question or not, it's a super cogent point of where we are at and where we're going. Yeah, I mean, I think the pandemic money that we've received, I mean, we've needed to spend an amazing amount of money in the public health for, you know, all of the response needs. You know, honestly, I mean, the thing that I think is really exciting for me, and I think relates to the public health modernization, I mean, the expansion and partnership in direct funding of community-based organizations, which had not really been a core strategy because there wasn't really enough money to probably do it in the public health system before. To have that opportunity in there to augment the work of the Community Partners Program that OHA has, I just think that sustainability of that funding is so important, because we now have augmented and provided support for so many community-based organizations to do more work in, you know, the response to the pandemic. That continued work in an ongoing sustainable way is super important for everyone in Oregon. However, I think you've hit it. Public health funding, fully funding public health modernization from the state side, and being very creative on the federal side to not have as many cliffs as Brenda pointed out, I think are sort of the two big challenges ahead of us of how to do both to keep, as you said, less yo-yo, more sustainable money, to have a better augmented public health system that supports local public health, but also has direct support for community-based organizations going forward.
I think we need to move on. Thank you so much, Dave, for the presentation, and thanks to the board members for the great questions. As we move on, I'll just, Dave, one of the things that's important for me is to make sure that the resources don't just go to the folks who have the relationships and connections in really powerful positions that get to make the requests and asks, but that there's also a very thoughtful and intentional process to really reach the communities that are most impacted. So thank you again for your presentation. Okay, next we have a legislative update from our government affairs team. Holly Heiberg, who is a director of OHA Government Relations, and Jeff Scroggin, the senior policy analyst with the government relations team, are here to discuss which bills are still standing and what's on the horizon. So Holly and Jeff, please, thank you so much for joining us, and take it from here.
Well, good morning. It's good to see many of you. I haven't been able to join during session, so it's a pleasure to get to come after this first session deadline and before the second one and check in. So we're going to do a presentation. I don't think it'll look terribly different in structure from what the GR team has presented at other policy board meetings. And I would just say my preference is that you just ask questions when you have them, and we just consider this more conversational. Next slide. Hopefully you've seen this slide in our presentations. It's the backbone of how we're thinking about our engagement with the legislature, and everything that we're doing, every bill that OHA has drafted, and the work that we're prioritizing is really to try to help move towards that strategic goal of eliminating health inequities in 2030. And the legislature may have heard us say this a time or two or 100 when we're engaging with them. Next slide. This is just something to keep handy. Our team does change from time to time. You have heard from members of our team. I know that Angie came and highlighted some of the public health work in particular. We now have Tristan Fernandez, who is moving forward the behavioral health portfolio. You had heard from Annalise at an earlier meeting, and I'm happy to answer any questions here today too. I'm working closely with Tristan in that portfolio. Of course, you all know Jeff Scroggin, and he's been doing a tremendous lift along with Jeremy in helping our legislature stay focused on healthcare transformation. And then I would just add, at some future date, I would recommend Belle Shepard coming and talking a little bit. I can as well touch base today on where we are on the Real DSOG bill. But Belle has really been lifting that bill, working very closely with Rep. Nose, Rep. Salinas, the governor's office, the Racial Justice Council, and all kinds of partners to get this bill over the finish line this session. Next slide. This is just a reminder of dates that have happened that are important deadlines with the legislature, and those that are coming up. And so we're within 10 days of the second chamber deadline. I will tell you, all the OHA bills are moving along just fine. We're fine with this deadline. The one to really keep your eye on is this revenue forecast, May 19th. We're seeing a whole lot of bills move into the Ways and Means Committee. There is a large stack. And in years past, I would say you would see policy committees may have broken down and chosen not to send certain bills to Ways and Means because they were just too expensive. And we didn't see that kind of a speed bump for any bills this session. So there is a very large stack. And the Ways and Means co-chairs have been pretty clear. They're only going to release to the subcommittees those bills that they want worked. And so that's being held pretty close right now. We're watching carefully. We expect to start seeing some movement in Ways and Means in a couple of weeks, or a week probably at this point. Are there any questions about that? Okay, we'll keep moving through. Oh, sine die, I'm always very hopeful that we will end before that date, but I would say, considering where we are in this session, we're probably going to go for the full thing. All right, next slide. This is just capturing where we are in the universe of bills. Really no surprises here. We saw, a vast reduction in the number of bills we have to think about after that first chamber deadline. I often compare it to that big first hill in a roller coaster ride. And then you swoop down, then the next one comes and it's much smaller. So we see probably less of a strainer for the second session deadline. There will be a reduction, but not that many. And you can tell we have a universe of bills. It's about 500 that we're tracking as a team and in the agency that are really important to OHA. Next slide. All that I really want you to know from this slide is, when we're thinking about health equity and we're thinking about the bills that are moving forward and the policy option packages, and we're really trying to think about it as much as possible in these three buckets that we have here. How are we reducing health inequities in our communities? How are we looking at and reducing health inequities and structural racism in the healthcare system? And then, of course, behavioral health is such a large part of our equity work, and it is truly this area that we have a lot of focus on for this session. So that's kind of how we're roughly thinking about these bills and bucketing them as we're trying to move through the session. We also, you'll see these slides coming up, OHA doesn't have all the good ideas, nor should we. And so we're trying to make sure we're highlighting some of these bills that really move us forward in equity, that our partners have introduced, that legislators have introduced. So you'll see a little bit more of that on the slides to come as well. Next slide. And, this list should not look brand new to you. I think Angie ran through a lot of the bills and pops on this list before. Let's see here. I welcome Jeff to step in on any of these slides because he's working a lot of these initiatives too. The big one I would mention here, you guys just had a great conversation about modernizing public health. From where I sit, this is what I've heard. We came forward with 30 million. Director Allen was really clear that he wishes, one of his regrets was that we didn't ask for more in past sessions for public health modernization. Advocates have come forward to the Ways and Means Committee during their roadshow and public testimony and have been clear that 30 million is great, 60 million would be even better and closer to what's needed for an investment right now. There's some scenario documents being put together that CLO in public health will be working to bring forward to the legislature so they can really be concrete about what these investments will mean. And I do know, and to Dave's point, we're now that we really are investing in our public health system in our community partners and CBOs, CBOs are stepping up in a really great way and talking about what these investments would mean for the work that they're doing in communities. And I mean, that's just fabulous. It's not the conversation we had in the past. I'm glad it's the one we're having right now. That's all I got on this slide. Jeff, did you have anything else on this one?
I have one just general quick note for the board. As you saw on our agenda today, we have more time than the past couple of updates, and I brought my boss. So please consider any hard questions you may have right about now. We have the time and the people for it. That's it for me.
We may give each other a little bit of a hard time on the GR team. All right, go next slide, please. All right, on this slide, I do think these are a lot of partner bills. I think everything's moving along, and I believe Angie briefed you on this. Maybe one of the great things, I see some tobacco pieces. I think we all have recognized it's been great to watch where we weren't able to move forward our flavor ban bill, but the feds have taken some really great action in the last week around menthol, cigarettes, and flavored tobacco products. So it's good to see that that policy is moving forward one way or the other. Jeff, did you want to say anything on telehealth?
Yeah, there's a couple on here we could talk about. Telehealth 2508 is pushing forward by a coalition, and Representative Prusak and other sponsors in the legislature really ratifying some of the changes we've made on the Medicaid, but also spreading them to the commercial side. So a comprehensive bill that has passed out of House Healthcare and is being considered in Senate Healthcare now. Another interesting one on this list would be 3108 right below it. And that's similarly Representative Prusak's primary care legislation, which does things like talk about how many primary care visits should be expected and ensuring folks have primary care providers assigned within the Medicaid system, and some other technical primary care related components. And similarly was heard in House Health, and I think actually has a fiscal component, so is moving forward to Ways and Means, whereas telehealth doesn't have a fiscal component, so is moving forward in the Senate in that committee.
I have a question. Could you talk a little bit about remind me about social determinants of health, the HB 3353?
Yeah, I can say a little bit about this one. House Bill 3353 is brought to us by co-chair Rayfield of the Ways and Means Committee, and is really focused on Oregon's 1115 waiver and prescribing certain components that might be part of that waiver negotiation. It's focused specifically on health equity, which aligns with where the state is going as it relates to the waiver, and has some prescriptive components around CCOs investing in health equity and behavioral health, and including community to direct those investments. Does that answer your question, Oliver? Or Oscar, sorry.
Yes, it does. Thank you.
And Oscar, I would say this probably needs to be retitled on the slide. It sounds broader than what it is. All right, next slide. All right, looking down this list, how about I'll take on Real D SOG for a second, and then Jeff, do you want to talk a little bit about where we are with Cover All People and the two options on the table? Okay, so really great work over the last month on moving 3159 forward. And we didn't know we were going to get there, but when it moved out of House Healthcare, it had full bipartisan support. And in fact, it has a fairly decent sized fiscal on it, and that is for a good reason. It's because we did some deeper work and really understood what it would take to have OIS really do the work that's needed to have a robust system for practitioners to enter information and for Oregonians to be able to see their own information. So that's all been worked out in the fiscal for 3159. And when it passed out of House Healthcare and it had bipartisan support, Rep. Salinas talked to Rep. Hayden on the record about welcoming his support in Ways and Means when we have to move it out of there. So it was really interesting hearing, and bodes well for moving it out of Ways and Means. It is also helpful. Rep. Nose, who's our sub co-chair, is the sponsor of that bill. Are there any questions about that bill? Okay. Jeff, you want to talk a little bit about Cover All People?
I do want to talk a little bit about Cover All People and any other bullet on this slide. This slide in particular has a lot of pieces on it that are big in our health policy space and for coverage and health equity. I might warn Jeremy, there are 2081s on this one, enforcement of the cost growth target. So I might ask you to maybe, if you have any comments or updates for the board regarding that one after I talk about Cover All People. And then I do want to talk a little bit and give a brief update on the public option bullet that was added on this slide. So the first bullet, just to take that apart a little bit, there are two bills which have different components of a Cover All People concept. House Bill 2164 is the Racial Justice Council and Governor's Office legislation, which is an expansion of Cover All Kids. It provides for kids who've aged out of Cover All Kids to have care, and the parents of Cover All Kids to have care. It was amended that way in House Health. There's an initial recommended investment in the governor's recommended budget for this as a kind of pilot / expansion of about $10 million. The legislature and several Representative Campos in particular brought forward a separate piece of legislation. I believe it's House Bill 3352 or 3. And that legislation, I think it's 52, is a broader expansion. And rather than maybe saying it's an expansion of Cover All Kids, I would say it's a coverage expansion, and it would really cover all folks who, but for immigration, would be covered under Medicaid. So if you would have been covered under Medicaid because you fit in the Medicaid adjusted gross income levels, but for immigration, you would be covered under this legislation. So this is a more sizable coverage investment piece of legislation. This bill was voted out of House Health and moved forward to Ways and Means Committee as amended. So it's being considered for funding through Ways and Means. Whereas House Bill 2164 was amended, as I mentioned, and then moved to the Rules Committee. And the Rules Committee is not subject to those deadlines that Holly shared in our initial slideshow or our initial presentation materials. So they have more time to consider an expansion in House Bill 2164 in that committee. But the other vehicle is sitting in Ways and Means and is probably a little more primed to move. I think it's worth noting that both of these bills are still alive. And I think that's intentional so that there's another backup waiting in the wings if something should happen or another direction should be negotiated or go forward for this coverage expansion component. So any questions on the Cover All People expansion / coverage? Great. I think we're in a little bit of a holding pattern to see how this is going to evolve in the Ways and Means conversation and the funding conversation. I also wanted to just briefly talk about the cost growth target, but I'll see if Jeremy's on the line and has any updates for us on that bill.
I'm here, but go for it, Jeff.
Okay. House Bill 2081 was heard which is the accountability and transparency components as recommended by the Senate Bill 889 Healthcare Cost Growth Target Implementation Committee. It puts those recommendations in statute. It was amended to do that and voted out of House Health a bipartisan vote, and then came out of the House floor on a bipartisan vote, and then was considered on the Senate Health Committee and received a bipartisan vote, and is awaiting its final action in the legislature, which would be a vote on the Senate floor. So when that happens, it will then move to the governor for signing. This bill's in pretty good shape because it's actually not in Ways and Means, so it's not taking that funding trip. So as soon as the Senate is able to vote on the bill, we should be able to move forward with signing it.
Our general philosophy has been push hard, push early on all OHA bills because we don't know how long people are going to stay in their seats. And so you'll see we moved early on all these deadlines to get our bills moving.
The other one I wanted to mention on this slide just really quickly is this in orange at the very bottom, the public option component. And like Holly said, the orange bills here, a lot of them are not OHA bills, but are priority bills of interest to the agency and stakeholders. I think would be of interest to the board. This bill is a bipartisan bill between lots of legislators, but including at a leadership level, Representative Hayden, Vice Chair Hayden of the House Health Committee, and Chair Salinas, Representative Salinas, who's Vice Chair of the House Health Committee as well. They both had public option bills that did different components, different things. I would say Representative Hayden's bill moved a little further into implementation, whereas Representative Salinas's bill moved forward with some of the steady components that the agency has been working on for a couple of years now. So they kind of melded these two together. There's not authority to implement a public option in this bill. However, I would say it's more than just the studies. There's a look towards like implementation studies and legislative statute changes that are needed to enact a public option. So kind of keeping the focus on where we need to study specific complex components of a public option, but moving into implementation planning at the same time. And that kind of completes my update on this slide.
Okay, why don't we move to the next one? There's no more questions. All right. I think, Jeff could give you the rundown, but overall, the movement of moving the marketplace over to OHA, that's going well. I don't think we have any problems there. Is there anything to add to that, Jeff?
Nope. Waiting consideration and Ways and Means. The bill is unamended and is in Ways and Means waiting for the consideration. Yeah, nothing to add.
Well, only thing I'd add, and I don't know if the board is tracking it this closely, but we've adjusted the timeline a bit. So we're doing all the planning now, but the actual move wouldn't happen until after the next open enrollment period, so we can make sure that the marketplace team and their partners can be really focused on open.
Yeah, that was good input we got from partners that made the adjustment. The other thing to just note, I mean, again, it's a partner bill. It's not OHA's bill. We did have an early version of a bill we introduced, but that's not the bill that was priority on mergers and acquisitions. And, again, this one is sitting in Ways and Means, and we'll see what happens. I think that that's a place where there can be quiet energy to try to not move something forward without coming out in direct opposition to it. So we're all watching that bill carefully to see what happens. Is there anything else to note on that, Jeff, or any of the other bills on this or the board that they haven't heard?
I think I mentioned this last time, but House Bill 2079 does contain a component that directly calls out the Oregon Health Policy Board. It has the policy board kind of helping determine and develop criteria for the review that the bill calls for, or determining when that kind of review should take place. So just to call out, if this bill is to pass, I think we will be talking to the board about criteria for material change transactions between healthcare entities.
Jeff, my question was going to be around that, because you said that or it was Holly who said that the OHA version is not moving forward, but a partner bill is moving forward. Does the partner bill still have the component where the board would sort of kind of help with overseeing this?
Yes.
Okay.
Yes, Oscar, it does. I checked this morning just to make sure. Yep, it still has it in it.
Okay, thank you.
See John's hand.
Yeah, along the mergers and acquisitions, does the bill really position itself as specifically focused on health equity? That the mergers and acquisitions, the action that the bill would result in would have an impact on health equity? That's interesting, if that's the case.
Yes, it does have that focus. The idea is that mergers and acquisitions haven't been reviewed for health equity and access in our communities in this way, at least in the state of Oregon. And I'm sure Jeremy or Jeff can speak more to this. There have been other states, a couple states that have moved more in this direction, and they have seen an impact of what has happened. Is that fair, Jeff?
Yes, I think that's fair. I would say that, at a very high level, Dr. Santa, the AAA priority, health equity, and transparency are all major drivers and intention, as I understand it, for this bill. Public transparency around what's going on,
right,
and ensuring we meet our AAA, which includes access, and calling out clearly and directly health equity.
You're good at what you do. I got a note from
this one. I don't know what's on the docket for our upcoming webinars, but it might be good to sort of think about a potential more of a deeper focus on this one, since it is connected to the Oregon Health Policy Board. Maybe just something to consider.
That's a great idea. We'll talk to Tara about getting that scheduled.
I think that'd be great for y'all to think about whether this passes this session or another one.
Some of this work builds off work the board did, way back when they kind of defined health equity and talked about what should happen in these transactions, and should there be a role, and what should we be looking at. So this is kind of the continuation of that work in some ways. So it really makes sense to dive a little deeper.
Are there any other questions for right now? Sorry, I can't see everybody on the screen, so I'm trying to like click through, but other questions for folks, for Holly or Jeff? Okay.
All right, let's go to the next slide. And y'all are welcome to bring up something if it comes to you later, and then we've passed by the slide, that's fine. I'm not a particularly linear person, that's totally fine. All right, here we go into behavioral health. A very interesting and dynamic portfolio of work this session. You know, Dave presented on the Getting to Awesome exercise, and if nothing else, I think what that exercise did as the discourse with the legislature is that it stopped this conversation of, well, what do you mean that $10 million I invested, you don't have a result to show for it? What do you mean that $30 million, we're still having poor outcomes? What we did is we scaled this to the kind of investment that would really make a difference in the state, and it has shifted the conversation. So if we get nothing else out of this session, I think we have done something real in reframing what kind of investment and the scale of investment is needed in behavioral health. A couple of things that I think are super strategic that the legislature did in preparation for this session. Last long session, they established a subcommittee in the House side for behavioral health. This session, they have the full House Behavioral Health Committee, and the conversations that we've had in that committee have been robust and moved to a policy place where people are starting to really get focused on the areas in the system that need an investment now. And there was a really great hearing yesterday with on the state hospital, and a much deeper understanding that you need to invest in community behavioral health and you need investment at the state hospital. People are really fully getting to a place of understanding the continuum of care in a way that they didn't in prior sessions. And this is resulting in having more discipline about bills. So you're going to see a lot of bills and pops, but there's a sort of momentum and consensus building around a handful of legislative vehicles that are really transformational. They're also very expensive. So now they will go to this debate that's going to happen in Ways and Means. So I think there's some really good work already in behavioral health space this session, and this is the place I think has the biggest potential for change coming out of session. We'll see how it goes. So I'm going to mention some of those big vehicles. I will try to answer as many questions if you have them as I can. 2086 is one of the big vehicles. That one came from us, really from the work OHA and the governor's office did in convening the Governor's Behavioral Health Advisory Council. And many of you participated in one form or another in advising that council. And it's been a great piece of work that has had tons of support and really moves forward those areas around service and programs, less in housing, but there's some piece to that in connection to other bills. And then, of course, the workforce recommendations started here and have moved into another vehicle we'll talk about in a minute. But the path has been paved pretty well for HB 2086. I think if I've got it right, it is about $75 to $80 million in general fund. So that's one of the bigger vehicles. And if that passes, we will be really making a big difference in the services and infrastructure offered in the state. And I don't think you can ever talk about behavioral health without talking about where we really need to grow is having linguistically and culturally appropriate services. So you'll find that that is at the heart of all of these bills. And I just need to say that out loud and be explicit because that is the biggest area of growth that we need. The other one, on this side, let's see, yeah. So the other two actually that I want to bring up is House Bill 2949, the Behavioral Health Workforce, and one that you may know less about because it's been more of an emergent piece is the Crisis Response HB 3069. So 3069, let me back up and say the federal government moved forward with this new service, 988. I'm not sure how aware you all are of that. It is the 911 for behavioral health. And I think it was October timeframe. They're like, here you go, states. Fabulous, we're doing this. 988 is here, it has arrived. And you can pass a tax in your state to help cover the costs of really having a robust crisis response to move along with this 988 number. That is fabulous. I think we are all aware that raising taxes in the state of Oregon is a difficult lift. It is not impossible. We started out the session taking the temperature, and we're still very much working with legislative leadership to see if we can fund this crisis response work either with a tax in general fund, or starting out potentially with some ARPA money and then moving to a tax in a different biennia. So those are some of the conversations going on right now. We're having really great conversations with county partners who have really been on the hook for crisis response through the years, and what this could mean transformationally when we have true funding for crisis response and coordination. So I think that's pretty exciting work. It could really change at the front end of the continuum work, exactly how we respond to people in a behavioral health crisis and get them routed to where they really could receive the best care at that time.
Can I jump in and make a comment on that one?
Yeah.
So this is Ebony. So yeah, and I totally agree that, 988 is super exciting. And, I think, the more that we can have these, highest levels of continuity and coordination, especially when it comes to our behavioral health crisis system and response, is important. And I also just want to highlight the importance too of the balance of the localities and the importance of, the role that, the local partners, stakeholders, and system plays, and that, I believe that it's going to be important to have that balance, in addition to continuing to also on the other end of the continuum, continuing to ramp up and establish actual treatment services to address the need. Because I think too, just one of the concerns that, I've heard a lot of questions around is, okay, so let's say that, we get to this, coordinated access around our crisis response, but then we have limited access or limited capacity in terms of service providers, treatment providers. And so, I just, there's a whole system approach, strategy, and need. So just wanted to say that. So thanks.
I'm so glad you emphasized that. And I think that's part of this, right, Ebony, is if you just moved that bill and you didn't really move the investment needed in workforce, in the investment needed in the services and the infrastructure in 2086, it wouldn't work, right? It would be out of balance. And I'm just going to use that as a bridge to move a conversation on 2949 to Jeff, who is the lead for OHA on that bill.
Thanks, Holly. I almost interrupted to be like, well, what about 2949? Same thing. So I haven't had a chance to talk much about this bill. This bill is really focused on the behavioral healthcare workforce. For the board, I think this is important because it will likely utilize the Healthcare Provider Incentive Program and the Healthcare Workforce Committee, which reports to the board. I think that the biggest news to share about this is the size of the investment is transformational and monumental as proposed in the legislation currently. It's about $200 million for behavioral health workforce. I think right now the budget's a little less than $20 million for all of workforce incentives for that committee and that program. So this is not a huge deal. This is a transformational deal if this bill passes and this investment is made in behavioral health workforce. And I think to Ebony's point, while we're talking about the legs of the stool in the behavioral health system that kind of are constantly trying to stand up while we're sitting on the stool, this is a huge one. And this would be, more than just tape on that leg. I think it would represent a new construction and a really bright spot in the workforce development for the Workforce Incentive Program and Committee. So I have to see how it moves forward. It's currently in the Ways and Means Committee, awaiting referral to a subcommittee and further consideration.
These three bills we've just been highlighting are if we didn't have any tax component for 3069, these three bills would be north of $500 million together in general fund. And there's still other pieces. And many of these are important, like peer respite is something we're very supported. At one point it was going to live in 2086, but Kevin Fitz has done such a great job championing this concept. Everyone wanted to make sure that that had its moment to shine as its own entity and get highlighted. And so that is why it sits outside of these bills. And that's it. I mean, it's very much the path is paid for that bill as well. Anyway.
Can I go back? I missed one important detail on 2949, I should say. I feel bad, but I want to point it out. Is that okay? That point is, this bill, the behavioral health workforce bill that I was talking about, 2949, it's not just a transformational investment in behavioral health workforce. It's really focused on communities of color and health equity. And I didn't say that about the bill when I started. And it's a really important component of the bill. It's not blanket workforce. It's not even blanket behavioral health workforce. It's really specific to communities of color and priority populations as it relates to behavioral health care workforce. Just wanted to make sure that note was in the record.
And anytime you all want a more briefing, we're kind of geeking out. We just love what's happening here in behavioral health land. And I just think at Steve Allen and Dolly, they're doing such a tremendous job and doing such a great job working with legislators and really getting very deep on these policy ideas and why they matter. So maybe when things settle down a little bit, I would even say there could be something, if it's helpful to you all. I think having a wider array of the folks who've been working on these behavioral health pieces, once we know how they're really going to shape up in the legislature, it's probably worth you might want to either ask us directly, or if there's time and you want people to come back, we welcome bringing some people back to have a deeper discussion on these. Sorry, we talk a lot and we really get passionate about this. All right, next slide, please. There's a lot of things that cost money on this slide too. So everything we've been talking about in the north of $500 million range doesn't even include ballot measure 110. One of the things I like that's happening around ballot measure 110 is that we're working with the council. We got out requests for proposals for services in a new way to really seek out providers that may not have applied in the past and bring down barriers for providers to apply for money. And we really put a lot of criteria in there about linguistically and culturally appropriate. And we're getting it back proposals. I just talked to Wes. I believe it is in the next couple of days we get back the proposals. And so we'll have like this beginning stream of money associated with Measure 110 to start pumping out. The legislature gave us $20 million early to start building that ramp to get the money out. And another important part of that, of course, is it's really about co-occurring disorder, which we all know is the space that we really need to move forward in as we think about providers, treatment programs. So all of that is very exciting. The bill that will further form what Measure 110 looks like, SB 755, the Senate had something like 36 amendments, lots of ideas. It's gone over to the House side. House Behavioral Health Committee had a hearing on it. It's all a haze, but I think that was last Thursday. I have spoken to a couple different legislators on that committee and suspect highly that the speaker will be putting forward an amendment on SB 755 because there's still a lot of questions and a little bit of cleanup there. But overall, I think it's maintaining the will of the voters. It really is moving down the path that the people who worked so hard on ballot measure 110 what they wanted. So that's the only one. I could go all day again on things on the slide, but I think that's probably it that you need. We are seeking that state hospital investment, and it's a both and the rest of the continuum of care. Just want to be very straightforward on that. Any questions? All right, we will move on. Oh, we're near the end, so this is good for you all. So this is just a rundown of OHA bills. And this is like our little cheat sheet, you know, what's passed, where is it now in status. It'll get another update here at the end of the week, but you can kind of tell, I think it's this slide, and I think we have one more that's a little bit spillover. You can see where the OHA sponsored bills or governor's bills are. And we've discussed all of them. This is just another way of looking at it. You want to go next slide, please? Yeah, there's the rest of them. Are there any questions?
Kirsten.
I guess first to say I'm excited about so many things on there and hopeful about not only how they help us, how I could see these helping us to achieve our goal in 2030, but also just, you know, moving things forward. There's a lot of hope, and with this, the ARPA money too, just anyway, so very exciting updates. Thank you for pushing this for these improvements. I know that there are specific bills that mention our board and therefore you keep us apprised, which very much appreciate that kind of heads up before work may come our way. Is there any other role that you'd like the board to play in supporting this work?
That's a great question, Kirsten. I think your leadership, you all have so much good experience. And I feel like as individuals, I see you. I see you in these meetings, and I think it's wonderful. And then I think it's, as a board, I think it's great that you're tracking this, what are the important conversations. You can give us your feedback and thoughts, and we should take that forward as part of one of our important advisors in how we move out this work. And I'm sort of dancing around, or I don't have a great answer for the more specific piece, should the board endorse this, or go talk to a legislator about that. I'm not sure. I think you play such a great role as sort of this independent entity right now. And, you all are influential in what you say to us and what we can carry forward. And you're so influential in your roles outside of the board. So I'm not sure.
I think that is a perfectly fine reaction. I'm not looking specifically for us to endorse bills. I more want to make sure that as you're giving us these updates, that you're getting what you need from us. Because this is reflective of a lot of work, and and come regularly to us. Want to make sure that you're getting what you need from us, because I don't know if you want us to be like, oh, that's a really interesting bill, and have you thought about this? You need a 39th amendment on that one. No, just kidding. I don't think you want us to do that. But anyway, I want to make sure that you're getting what you need from us.
I think that the first thing is we want you all to feel like you're getting what you need from us. We want to make sure you're updated, and we want you to have no surprises. And then now I love this idea. Are we getting what we need from you? So I would say that I really admire the people on this board and your experience. And I would love for you, either in these meetings or after you've had an opportunity to reflect. I know I'm this kind of person. I like to take it in, reflect, and about 24 hours later, I got a question or a thought to share. And I would just say, please don't hesitate. We come to you because you are very smart people with a lot of experience. So do bring that back to us. We welcome your feedback. And It's better for us to get the stuff right up front. That's what we're going for. So it's not more work. If you have an idea, it's something we should probably be thinking about.
I have a take on this too, just really quickly. One of the things that I think is helpful is when the board kind of fulfills its oversight role as it relates to the legislative process. So like saying, I think you're missing a shall there, that's very prescriptive. But saying like the question came up, are we talking about equity or are we talking about access? That's a really good oversight function for us. Like what are we talking about in this bill and what is the agency's priority? So I think that kind of engagement where you're asking us, well, which direction at the highest level are you going for this bill as it relates to the agency's work plan or 2030 goal? Those are helpful, even public reminders for us.
Any other questions from the board?
I just want to voice my enthusiasm for the work in behavioral health in particular, Holly and Jeff. Thanks so much for your detailed work and preparation for today. And I join you in the level of enthusiasm that this, excuse me, this transformational moment causes for our state. So I feel, really compelled on the record to say that the work that OHA is doing right now relative to these heavy lifting items that we have been stymied by for decades, beyond decades, particularly in recognition of the issues and needs for BIPOC communities in particular is profound. So I'm thrilled. I look forward to the future webinar where we get to dive in greater detail around what actually lands at the end of the day, and then what our continued role is to continue to keep this momentum moving forward. So thank you for that.
Thank you, Brenda. Any other final comments or questions from the board? Well, I just want to thank you both, Holly and Jeff, so much for the detailed presentation and update, and the entire team leading this process. That's a lot of bills to be kind of tracking and following and advocating for and pushing forward. So thank you so much for all your excellent work and moving so many of the board's priorities, including behavioral health, cost containment, and expanding coverage. So thank you. We're going to move on to the next item on our agenda, which is public comment. The Oregon Health Policy Board welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will, however, bring it fully into our awareness, understand it as an important consideration of our work, and listen with that kind of careful attention, respect, and honor that it deserves. Each presenter is given 2 minutes to share. And in the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a slide with a 2-minute timer for each presenter. We kindly ask that presenters conclude their presentation when the timer is complete. Please note that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. For today's meeting, we received one request for public comment from Paul Turtle. Paul has requested to share verbal comments on OHA's Medicaid waiver and has also submitted written testimony, which was included in our meeting materials. I believe Paul is here and ready to go. So Paul, when you are ready, please feel free to share your comments.
Thank you. Can you hear me okay?
Yes, we can.
Very good. So thank you, Mr. Chair and the members of the board. So my name is Paul Turtle, and I am a resident of Northwest Portland, and I am testifying as a member of the public and as the father of 2 Medicaid-eligible children with disabilities, as you noted, to provide comment on the upcoming Section 1115 Medicaid waiver renewal application. There are 2 critical fixes that should really be included. First, please remove the obsolete EPSDT waiver provision. And second, please declare that you will not be using quality or quality adjusted life year metrics in the prioritized list. For EPSDT, the federal government's purpose is to provide all medically necessary diagnostic and treatment services for children under the age of 21, regardless of whether or not such services are otherwise covered by the state Medicaid plan for adults. Oregon, so far as I can tell, is the only state in the entire country that reserves the right to withhold medically necessary care from children solely for the purpose of raising money. There may have been a legislative purpose for that or a policy purpose for that 30 years ago when OHP was started, but it's time to move on from that. There has been a drastic increase in funding and in coverage for access to healthcare, particularly for children, and it's really time that Oregon, drops that EPSDT waiver and moves forward. For qualities, this is a tool that values the treatment according to years of additional life adjusted for the level of disability. The effect is to automatically discount the value of the life of people with disabilities. It has been used in ranking services on the prioritized list. It's discriminatory, and I would ask you to insert a provision saying that you will not be using it in the future. Thank you.
Thank you so much, Paul. As I already mentioned, we will not respond to what you just shared, but please know that the board chairs and leadership will discuss this at a later meeting this week. Okay, it's time to take a short break before we finish off the second half of our meeting. Let's go ahead and plan to return in just over 10 minutes. So we'll start at 10:20. We'll be back at 10:20. We'll go ahead and get started here in a minute. Do we have Director Allen back yet? Jeremy? Oh, I see Jeremy. All right, welcome back. So OHA leadership is back again this month to share information on OHA's Medicaid waiver efforts. We are going to be joined by Director Allen, Medicaid Director Lori Coiner, and Health Policy and Analytics Director Jeremy Vandehey to learn more about the waiver, community engagement efforts, and deep dive into the global budget. These materials were included in your packets and materials. So I'll go ahead and hand it over to Jeremy or Lori to kind of lead us off here.
Good morning, everyone. We have a set of slides so we can bring those up. Today we are going to, while we're bringing the slides up, I'll just kick off. We are going to talk a little bit about where we are in engagement with community partners and other stakeholders. And then we also, and I'll review policy just on one quick slide to refresh everyone's memory, but we're going to take a deeper dive into some initial thinking around the global budget. And it's one of the four main policy areas that we're focusing the waiver on. And I believe we'll have plenty of time for discussion at the end. We don't have lots of slides, so we really want to have some opportunity to answer questions and have discussion. So next slide, I don't know that we'll need, it's just the agenda. Next slide after that. This is a very high level calendar that shows how we're including engagement with community. And when I say community, I do mean, members of the community, for example, our community partners who work every day with our clients and our OHP members, the regional health equity coalitions who also work with clients on a daily basis, and then also other stakeholders that are interested in the waiver that where the waiver may impact them, like the coordinated care organizations. So when I say engagement, it's the full breadth of the both the communities we serve and the partners that we work with to serve those communities. So where we are here is in the April-July block. We've done lots in February and April around just much like the slide deck and conversation that we had last time, kind of let people know, remind people what a waiver is, talk about our high level policy framework. Now I think where our focus is a little bit more on roll up your sleeves and talk about the details of what is in each of those policies, and really hear from community about, what are the problems, what are potential strategies to solve those problems, and then getting into detail, and then how we'll evaluate the programs at the end of the waiver, of the 5-year waiver. We're in the beginnings of this, where I would say we've defined many problems. We've taken time to look at what community, particularly communities of color, have shared, for example, during our CCO 2.0 development, to lay out some of the problems. We're really beginning at this point to have those conversations again with folks about the drivers and barriers to those problems. So that's about where we are. And you'll see that there is also opportunity for engagement across the next 6 to 9 months. We don't plan to, we aren't submitting the waiver until December, and we see this as an iterative process. So it's, we are working on some draft concept papers. They're very high level, and those will start as a framework for people to give us feedback including our federal partners and the Center for Medicaid and Medicare Services. So next slide. We also are going to have a series of workshops that we're calling Waiver Days. And these will start in late May. They are open to anyone who wants to come. And the idea is that we will divide out into groups, and it will be opportunities for people to sit at virtual tables and really talk in detail about the waiver. Some of our partners, we can't meet individually with every single one. And so we really, these are opportunities, and more to come in terms of dates, but, to roll up sleeves, ask questions, give ideas, and the series of those waiver days, first is really around the problems, drivers, and barriers, and then subsequent meetings around potential strategies and so on. And we'll be covering all of the 4 goal areas. And just to remind you what those big policy goals are, take a look at the next. Oh, I think that comes after. I do have a slide that shows our work with community partners. So let's take a look at that one. We also have been working with our community partner team to develop webinars. There will be a series of 3. The first series is May 10th, so it's coming right up, and May 13th. Each of the series will have a webinar in English and one in Spanish. And this is another opportunity for our community partners who focus mainly on helping either Oregon Health Plan members fill out paperwork, or new potential Oregon Health Plan members learn how to and provide assistance in filling out applications and getting people signed up for Oregon Health Plan. So these partners are really key in understanding the difficulties that our members are experiencing and the kind of lived experience that many of our members have in their daily lives. Next slide. Here's an overall timeline just to remind you. I believe we went through this in the last meeting, so I'm not going to spend too much time on it, but we are in the spot right here where we're involved in public engagement, and we are working on concept papers just to kind of give it understanding that we haven't begun drafting the application. So we're not behind the scenes doing a lot of drafting before we reach out to the public. So we will begin here soon to draft the application, flesh out concept papers, and then take those back for more public engagement. Next slide. So here's the reminder of our 4 big policy goals, along with our overarching waiver goal, which is to advance health equity across Oregon. The first kind of big bucket there is, I guess, the first place to start thinking about ensuring access to coverage for all people in Oregon, some sort of insurance coverage, trying to expand our ability to retain our Oregon Health Plan members on the plan so that they can have continuity with their doctors, their service providers, and so forth, rather than churning, is the word we use, but really to mean having to lose their benefit and come back on, and it's very disruptive for healthcare. Then the second big policy goal is to create an equity-centered system of health. Lots underneath this. We're focusing, I think, really on transitions of care for folks. So thinking about people leaving criminal justice, people leaving psych residential facilities, children aging out of foster care are all times where they have disruption, and it can be very hard to get reestablished with your medical care. And many of these kinds of transitions are with people who are already struggling with social needs, and so investing more on the side of helping them meet their social needs, thereby increasing their ability to thrive. The green box there is encouraging smart, flexible spending through a global budget. Jeremy's going to walk you through that in a little bit more detail. And then the final is we will be asking the federal government that for some savings. We're going to be asking to share in the savings that we expect to see in our programs that are included in the waiver. And those dollars, the goal right now is to reinvest those dollars into communities and but broader scale investments that a single CCO might not be able to tackle on its own, such as improving behavioral health workforce, particularly with a focus on workforce that has cultural competency and language in the communities where they work. So I'm going to pass this on to Jeremy, and he's going to talk a little bit more about global budget.
Great, thanks, Lori. We'll go to the next slide. So I'm going to give a little bit of overview of the evolution of CCO global budgets and some of the challenges and where we'd like to be able to get to with CMS. We purposefully are not going deep into the rate methodology. There is a great amount of detail that we could get into, and we're trying to keep this pretty high level. Feel free to ask questions, we can answer them, but trying to be at the right level and keep folks awake. Overall, when we talk about smart, flexible spending, I think our goal is to ultimately keep pushing towards our vision in the state for sort of a global budget. And what that would look like, and recognize that this is going to be a negotiation with CMS that no state has gotten to where we would like to be able to get to, and so we'll also be sort of exploring a variety of other flexibilities or things, and we'll keep we're going to kind of go big, but also recognize that if we aren't able to get all the way there, we want to be able to get as far as we can and get as much flexibility as we can. The overall goal of the global budget framework in Oregon is really to be able to provide, twofold. One, to push the healthcare delivery system to operate within an established budget and to use that to really drive innovation, to drive change, to drive higher value services, and to move away from a system where, frankly, the healthcare system is sort of rewarded for higher costs, and more spending, and especially spending in things that are low value. And the idea is if we could get to a budget that would sort of force some innovation on the ground. The other piece was really to try to bucket as much of the dollars of Medicaid into one place, so the community could really help drive that and drive the dollars to the right place within the system that really promote health, and also provide more flexibility so that patients, members can get the things that they need at the time that they need them, that are going to keep them healthy, regardless of whether that's a healthcare service or something else. It wasn't necessarily to sort of solve all of our social woes, but to say if it's housing supports, if it's transportation, if it's food, if there's a thing that's not healthcare that is really what people need, let's get them the stuff that they need to be supported and to be healthy. So that's always been, I think, the overall goal of CCO global budgets. Where we want to be able to get to, and I'll get into a little bit more detail of this, is I think we do have a global budget. It's just not, I think, exactly built the way that we would like it to be built. And so we'd like to be able to get to a spot where it feels more like a budget and less like a rate. And through that, be able to provide more flexibility on the ground, more incentive for the system to invest in prevention and upstream. That's got to be coupled with strong consumer protections, though. The big risk or concern anytime we're talking about pushing down on costs or moving to something that looks more like a fixed rate of growth is making sure that folks still have access to the care that they need, that's necessary, and the full benefit package. The idea isn't to not have access to the healthcare that's covered. It's to also have access to the other types of things that sometimes would prevent a higher cost healthcare service. It's also really important that that there's a strong community voice in this, and that the budget's really supporting the overall goals in the community around health, and addressing equity, and ultimately, like I said, that folks are getting the support that they need to stay healthy. Next slide. You know, we do have a global budget, but I think what we really see when we're talking about kind of a future state of a global budget versus kind of the more traditional capitation model, it really, I think, has to do with how that budget evolves and changes over time. So the idea with a global budget is we obviously are going to have to base it off of something is you know, historically how much is needed to be able to cover the healthcare costs of the population that's served. But the idea is once it's established, it's fixed for a while, and it's really only growing at a sort of predetermined rate of growth, and is only being adjusted, you know, minimally for things like major changes in the population or risks, but looks different than how we've traditionally done capitation rates, where we have to adjust those pretty regularly, based primarily off of the most recent history on healthcare spend. And that's really the issue here, is trying to change the incentives so that we aren't just continuing, you know, to have to pay more and more into the system, and that the incentive is, frankly, that the more you do, the more you get paid. And so that's been the traditional issue, and I'll get in a little bit more detail as we go through this. But we will have to sort of define what we mean by a future state of global budget in this process, and are in the process of doing that, but are kind of starting from the place of, you know, really how this looks different is it is a budget that is really established for a period of time that's really not adjusted except for by a handful of things, and is more based off of a longer term history of what it's needed to cover the population, and not so much on just the recent shifts in healthcare spending. Next slide. The original intention of global budgets within Ccos, I talked about this last month, but there were a couple different goals, and we've really been able to achieve a lot of the original vision. But we've had to do it sort of incrementally over time. So one major goal was, as I mentioned, to try to get as many of the dollars combined into one budget for the Cco. Previously, before we had Ccos, we contracted with something upwards of like 45 different managed care entities between physical health managed care organizations, behavioral health managed care organizations, and dental care organizations, and non-emergent transport was paid for separately. And there were a lot of services that were carved out of those contracts as well. So the idea was to try to get as many of the dollars folded together as possible so that the community could really drive the spending, and that there was accountability across the healthcare system, across the physical, behavioral, and oral health system to work together and make the best use of those dollars to keep people healthy. And as we know, when the system sort of fails, people all they sort of end up in the emergency room or jail most often. And so the idea is, we need the systems working together, and a big piece of that was folding the dollars together. And we largely did that. There are some things that are still carved out, and we've had a lot of work over the years to try to get more and more into the budgets. The other piece of it was really to have it grow at a sustainable rate of growth, and to get out of sort of the annual rate making methodology that's really based off of last year's healthcare spend. That's been the harder piece. CMS has really got some pretty rigid rules around that, around having to look back at most recent healthcare spend. And so that's the piece where we've really struggled. And we've come up with a lot of ways to try to build in that same incentive for the system to live within a budget and to reward it for efficiency. But those have largely been things we've had to kind of tack on to the traditional rate setting process. But we have gotten a lot of flexibility from CMS in terms of how CCOs can spend, and they have a lot of flexibility today to be able to spend on a variety of things. The challenge is being able to see that investment show back up in rates and not feel penalized if they do a bunch of things that actually lower costs, and that's been a struggle. Next slide. So kind of evolution over time. There was a phase-in by statute when we first set up CCO global budgets. The physical and behavioral health pieces came together. Oral health didn't come in until 2014, so there was already sort of a prescribed ramp up. We had to go through, and Lori, I'll pause here in a second so you can jump in. Lori knows all about all of this much more intimately than I do, so I want to make sure she gets a chance to chime in here. We had to go through a process, I think, as folks remember, of actually completely redoing our rate methodology back in 2015 after CMS questioned the way we were doing it. So that really pushed us to have to really kind of double down on spending and really, well, it just required us to really remake the entire process. So that kind of happened in the middle of all of this. We had the ACA population come in and 350,000 new members who we didn't have any experience for. That took us several years to understand the risk of that population. So that was a big challenge in the middle of all of this. We moved to regional rates and away from CCO specific rates as part of that process with the changes in the rate methodology back in 2015 based off of guidance from CMS. And then we made a bunch more changes in CCO 2.0 to really kind of keep pushing us farther and farther, and again, really trying to fundamentally change the incentive on the ground to save money and be more efficient and to get patients the thing that's going to be, often the preventive care, the thing that's going to keep them healthy. So a couple of those changes in CCO 2.0 that are sort of still getting off the ground. We moved from regional rates to statewide rates, and the idea was really to ensure that if one CCO was doing things that were really reducing costs, that they wouldn't kind of protect against the premium slide issue of then seeing a cut in rates the next year, and moving to statewide rates was a big way to do that. We also are in the process of moving to rebasing rates every 2 years instead of every year. And what we mean is traditionally we've had to sort of make the rates and the global budgets from the ground up each year. So we're going to move into a 2-year cycle, but with sort of a next evolution of global budget. We'd really like to have that even be a longer period of time. Lori, anything you want to add up to this point?
No, I will add one thing in that. So I guess from a high level, in 2012, we ran out of time to negotiate what our original vision for a global budget was. And so there was lots in the waiver that was a little vague. And then, as Jeremy laid out, there have been lots of evolutions to our global budget, but we certainly have always, at the very beginning, integrated a bunch of funding streams so that the CCOs do get a amount that covers physical, behavioral, and dental care. So that's been a big win. I think the piece that happened in the last waiver renewal that we worked on quite a lot, and that was in 2016 with the approval in 2017, was that because of these evolutions and because we didn't get the global budget kind of developed the way we had envisioned at the beginning, there wasn't as much spending on health-related services. And what I mean by that are certain non-medical services that promote the health of members. Now I think we're using more of a term of, services that would meet social needs, but that sort of spending. And we did make some changes in the global budget and moved it even further to try to promote more spending in that region, in that area of health-related service, meeting member social needs, non-medical expenses. And we made more strides. So I guess I would say that, what we're thinking about in this next round of global budget is to push that even further. We really want CCOs to have the flexibility to provide some funding directly to communities who know what their needs are, to allow more flexibility for CCOs to spend in the areas of social needs where we know it keeps people healthier. And so that's the real goal of this, or one of the big goals of moving to a global budget, and doing that within our sustainable rate of growth. At a statewide level, across this time, we did adhere to the sustainable rate of growth that we committed to with the Center for Medicare and Medicaid Services. So,
yeah, just to put a little finer point on it, and I know this gets a little bit into the weeds, but to Lori's point around, we were kind of ran out of time. I mean, our waiver from 2012, which has stayed pretty much the same on the global budget piece, with one big exception, is it talks about a global budget and talks about the funding streams blended together, but what it doesn't do is provide any waivers of the federal regulations on how managed care rates have to be set. And so that's where we really run into some challenges. Is there's some pretty prescriptive rules around, as I mentioned, around the rates primarily being based off of recent healthcare spend, and as well as where you count things that aren't traditional healthcare services and rates, and that those largely have to be on the you sort of build a budget for CCOs that says, this is how much we think we need to pay you for medical, and here's how much we think we need to pay you for admin. And if you're spending on things that were not medical, we can add that to the admin side of the rate, but not to the medical. And so those have been some of the challenges that we've been trying to work through. The thing that changed in 2017 that was a pretty big shift was we got a whole category of spending included around health-related services, and so that was a shift. But one of the challenges here has been, I think when we really originally started talking about global budgets, we weren't wanting to be in a spot of counting all of the widgets all of the time and saying, okay, we need to be able to see everything you're spending and the return on investment. We wanted the community to be able to figure out how to spend and how to make the right investments. But to be able to navigate the federal rules, right now we have to count all the widgets, and we can only sort of give so much credit for the non-healthcare stuff. And so those are some of the challenges. So we've come up with a lot of workarounds, but it's also made the whole system and the whole idea of the budget much more complicated than I think we'd originally expected. Next slide. So what we achieved in CCO 2.0, and I do think we've come a long ways. I think through this process, even though it's been, I think a struggle to try to find that alignment between state and federal goals, we have gotten a lot of flexibility. We have been able to get, a whole category allowed and within the rates of health-related services. We've gotten a medical loss ratio that allows us to count things that are not just medical costs in the rates. And as we moved into CCO 2.0, we've made a number of changes around a variable profit margin that helps reward efficiency, around moving to 2-year rates, or rebasing every 2 years instead of every year, and moving to statewide rates. We think all of those things are really help evolve and probably have us at the most, sort of progressive global budget-like model of any state. But what we're worried about is we still aren't fundamentally changing the incentive on the ground to have the system feel like it needs to live within a budget, and that if it makes investments in one place that really reduce costs down the road, that they can see that, and they can they don't feel like they have to keep counting all the widgets and keep sort of showing the return on investment in order to not have rates cut down the road. I want to go to the next slide. I should note in CCO 2.0, we also built in more accountability within the contracts that CCOs are expected to be partners in meeting the cost growth target, and that's accountability for them as well. And then the other piece of this is the quality pool as well. So the part of the global budget always included a percentage of the budget that's tied to quality. That's at about 4.25%. When we started with CCOs, I think it was either 0.5 or 1 percentage point. And so it has grown and evolved. The whole quality program has grown and evolved over time. I think that the main challenge, and I've sort of already hit this, is one, there aren't built-in mechanisms within our current global budgets and rate setting process to really promote elimination of health inequities and to promote equity. That's a piece that I think is missing. There isn't a sort of built-in mechanism for that specifically. Second, I think it varies across the state how much community decision-making there is and how the budget is spent and where CCOs make investments. And a large part of that is because we weren't prescriptive on what that needed to look like when we stood CCOs up. So they all have a little bit different governance structures with different levels of and different ways that the community engages. But big goal of global budgets was that that the health system and other parts of the community are coming together to say, where do we need to make investments to be able to be more efficient, to provide higher value care, to be able to better meet patients' health needs wherever that spending needs to happen. We also have not seen, I think, as many shifts of dollars going to different places within the health system as we were expecting. We were, really, the idea of the global budget was not just to say everybody's going to continue to be paid exactly how you were paid before. It was to shift some of the dollars around and shift some of the dollars from places where we're spending kind of after the fact, after health problems happen, to places where really would promote prevention. And then a lot of places, at least what we hear on the ground, is it's still sort of the old same fee schedule as before. So we aren't seeing the system sort of make as many corrections in terms of where dollars go as I think we had expected. And then the big issue really is just trying to fundamentally get away from this incentive that no matter how many places we've built in flexibility or said, here's where you can spend, here's how you can spend on housing, here's how you can spend on other types of health related services, that the reality is we primarily have to build rates for CCOs based off of last couple of years healthcare spending. And so it's, the idea is we're trying to make doing the best thing for patients the easiest thing. And if the best thing for a patient is to provide a non-healthcare service, that's not the easiest thing right now. It's still probably easier to pay for a healthcare service and know that that's going to show up next year in rates. And so that's sort of the incentive that we're trying to fundamentally shift on the ground. And that's something that we need to get agreement from the federal government to be able to do differently. Next slide. Before I go into kind of future, Lori, anything else you want to add on challenges?
Nope, I think you covered it well.
So this smart flexible spending area with the waiver in some of our strategies and goals here. I mean, again, first and foremost, it's really to get to a kind of new definition of what a global budget looks like. Trying to end the cycle of inefficiency within the system. Low value care is still sort of rewarded in the way that we do rates, that we can see that show right back up in rates in future years. Really trying to push the system to provide to be more patient-centered and to provide the services, if those aren't healthcare services that really meet a member and community health needs. We've talked about, sort of short of that, we want to be looking at things like more bundle payments for certain complex needs, and we might want to think about some of that and sort of how a future global budget is built. There'll certainly need to be a strong consumer protection piece of this, and part of that we think needs to be able to really address and ensure that we aren't exacerbating inequities, that there's mechanisms to promote equity within a global budget, and also general access and quality issues. And part of one of the reasons I think we've really struggled with this at the federal level is for a long time, a global budget in Washington, D.C. has been synonymous with a state agreeing to a per capita cap on its healthcare spending or a block grant. And that's not what this is. This isn't about us asking the federal government to cap the amount of spending it's going to provide in Medicaid or limit enrollment. This is really around trying to get the local healthcare system to operate within a budget. But that's a political issue that we need to work through. And part of the reason that's a concern, or a big reason that's a concern, is appropriately the federal government and local and national consumer advocates and stakeholders are concerned that that anytime we're talking about pushing down on costs, we're trying to live within a budget that could result in access being denied or people not getting the medical care they need. And that's certainly not what we're talking about here. We're really just talking about the system working more efficiently for members. So we will have to build some strong consumer protection piece of this to ensure that accountability. We also want to be able to think about a stronger community voice, especially outside of just the local healthcare players, and how global budgets are leveraged in the community. And then we would see this as part of an ongoing commitment to a sustainable rate of growth. And a key component of our fourth bucket, which is, if we're successful in this area and are able to build a budget that keeps costs at our 3.4% growth target, that's about 2 percentage points below the forecast of national healthcare expenditures. And so can we share in some of those savings and reinvest them into places where we do know we need to make some targeted investments beyond a global budget, that a global budget and local flexibility isn't going to be enough to correct some inequities in the system, and those, especially when we're talking kind of more community-wide or more statewide, actually requires some investments appropriately outside the global budget. And so can we have those things work together? Next slide. I think that's it. Expanding community governance. I think this is a piece that's really going to be important for us to be engaging with the community on and learning from the RECs and Health Equity Committee and Racial Justice Council and others around where are they really seeing gaps and having their voice heard as part of local community investments, and identifying how we correct some of that. And so we do see that as a big piece of moving to a global budget. And frankly, it's a big piece of making sure that budget is actually helping correct inequities, helping promote equity, and protecting members. So we're just getting these conversations off the ground. All of this is, we don't have anything baked behind the scenes on this stuff. We are really just getting these conversations off the ground, both with community as well as with CCOs. Next slide. All right, with that, Lori, anything to add before we go to questions?
No, just ready for questions and discussion.
Thank you, Jeremy. Thank you, Lori. Any questions from the board? Brenda.
Thanks. I appreciate the timeline and the walk down memory lane of this really complex issue, and how the structural underpinnings really inform our collective behaviors in systems. So my question or comment are related to this kind of pendulum swing between, fiscal accountability on one side of the pendulum that has a lot of actuarial soundness and the narratives that have been around that in the CCO worlds, and on the other side where we're swinging toward, additional flexibility and looking at the larger impact and holding accountability for larger impact instead of, as you say, Jeremy, the counting of the widgets sort of thing. So my question is about, while we're recognizing that we've been in all places on this continuum, where we intend to set point as we go into these conversations with CMS and in the waiver process. If I hear you just in summary, you're leaning more toward the flexibility side of the equation. And I'm wondering about how we also tend to the question around the fiscal accountability and the actuarial soundness and all the mechanical things that go underneath that. So it's a little more philosophical, I suppose, of a question by nature. Happy to.
Well, I think you're spot on. This is the sort of the tension here. We're trying to build something that hasn't been done in another state. And frankly, even when we talk about global budgets, sort of in health policy, there's literature and there's a lot of examples out there of global budgets at a provider level through an accountable care organization model, or sort of an all-payer model where you might pay a hospital global budget. There's also a lot of literature out there, and has been for decades, around trying to move the broader health care system to a global budget, sort of across markets. There aren't really, I would say, good examples out there of the sort of in one market from the payer to the health plan, in this case, CCO, health plan, lack of a better term, but, so that I think that's a thing that we are literally building, that there isn't a model to say that's what we wanted exactly. And that's been part of the tension, I think, on this issue is global budget means a little something different to everybody. It's not like there's a long written out definition in statute. It just says, basically a blended funding stream that grows at a prospective fixed rate. I think it's going to be on us to define where we are in the pendulum. And you're right that, I don't think we get to a spot where we say, well, everybody gets a per capita rate and we're kind of done here, like we're just, it's going to grow at 3.4% into perpetuity. I mean, no matter how long the budget is set for, at some point we have to come back and set it again. And when we do that, we're going to have data to understand what we need to change about it. So there's some element of counting widgets we're never going to be able to get away from. And there's some element of counting services that's going to be really critical for ensuring access, for ensuring quality, for ensuring equity. So those are the issues that we're going to have to work through, is how do we continue to do this and recognize we're never going to be in a spot where we're sort of not paying attention to what healthcare services are being provided on the ground. That's really important. But how do we continue to evolve this in a way that feels more to the healthcare system like you have a set of money and you really need to figure out how to live within that.
Kristen, kind of question. I think I saw you raise your hand.
I do have a question. Thank you, Chair Arana today. I noticed, well, I guess I was kind of connecting the dots between some various presentations while you're chatting, and one of the slides mentioned non-emergency transportation, which reminded me of reading the Ombuds report not long ago, which really flagged that as a challenge for so many Medicaid members. And I'm not totally familiar with all the barriers that lead to those challenges, but just that it seemed like a big issue. And so I was curious if you could talk to how, I think I know the answer, but I'd love to hear you describe it, how this new vision will help address some of the challenges that we see with current Medicaid recipients.
Well, I think, sorry, Lori, you probably have a better answer than I do on this, but when I talk about we haven't seen as many shifts of dollars sort of at the next layer down as we'd expected. I said a minute ago, a budget that the healthcare system sort of feels like it needs to live within, but whatever, what we really mean by that is yes, there's the pressure of a budget you need to live within, but that's driving conversations around where do we need to make investments? Where are we gonna, where do we spend now that's gonna help patients a year or 2 or 3 down the road, and is gonna be better for members, and and at the same time lower healthcare costs or contain healthcare costs. And unfortunately, I think the way that we have to sort of still add up all of the healthcare spending last year and put it into rates is sort of just keeping most of the spending status quo on the ground in a lot of places. And so we aren't seeing shifts to places where maybe places need to be, dollars to be added. And I don't want to cast any broad strokes here, because I think these need to be community conversations. Do there need to be more dollars shifted over to behavioral health? Well, then the community should have that conversation and say, look, we're not going to solve this problem. We're not going to figure out how to live within our budget unless we make some shifts of dollars going from one place to another, and better meet patients' needs and get a better health outcome, so that they aren't ending up in the most expensive places in the system, which is usually the emergency room. So I guess the long way of just saying, our hope is that we were driving more of those conversations, and that there's more community voice in those conversations. Lori, what do you think?
I can address a little bit more around NEMT. So I'm not going to be very helpful. But I can shed a little light on it. So the non-emergency medical transportation benefit for Oregon Health Plan members is federally required. All states have to provide non-emergency medical transportation. So what that means is rides to medical appointments that aren't an emergency that you would take an ambulance. And it's complex. And frankly, Ccos, it's not a medical service that they're typically used to having to provide. So they rely on brokers and others to help with that. And it's a complex program. So, sometimes people need a particular vehicle, they need to transport in a wheelchair, and getting, staff training and all of that. And so I think that there certainly is lots that we can do as a Medicaid program to improve that doesn't require a waiver. It requires, really, as Jeremy mentioned, talking to community, understanding the barriers, taking what's in the Ombuds report, and then working on that within our Medicaid program. I will say, however, that, for example, North Carolina was in their waiver that was approved in, I think, end of 2018, beginning of 2019. They received authority to cover, what do they call it, non-emergency health care or non-emergency health services transportation. And that allows them to not only pay for trips to medical appointments, but also trips, say, to go get your supportive housing worked through with a community benefit organization. So it's a much broader definition. It's certainly something that we could look at for members who do have transportation issues, so that they can get needed social supports beyond just medical. So that I do believe that through a waiver authority, there are some expansions to this that we can look at to improve our programs. And then we need to roll up our sleeves and really, take a look at how to make sure that our NEMT programs are, providing the service that they need to. So hopefully that's helpful.
Yeah, and just in a very big picture level, I don't know, would it be accurate to say that, like, part of the vision that is being pursued in this waiver is kind of to change those underlying incentives so that, to change the underlying incentives. So it's not just a mandate to do this, but you're changing the whole dynamic in the system. Right.
And on the NEMT, there's lots of, because it's federally required, there's lots of federal, rules. So for example, we've requested under the public health emergency to allow NEMT drivers to number one, take someone to a vaccination, but also on the drive-through, stay for the 15 minutes, because there's federal rule that says they have to drop someone off and then they have to leave. And so it's, we have that, we're requesting, but there are these intricacies that just make the program harder. And to your point, yes, we want to eliminate a lot of those barriers as much as we can. So,
John or Ebony, do you have any questions? Oh, I see a follow-up question from Brenda, actually, but I want to check in with John and Ebony.
No, I don't have any questions. Thanks.
John.
Yeah, well, a couple comments. I think this month you've provided additional, detail that I think is really helpful and is helping me to understand more. I do think you're using these interesting phrases. Consumer protection, community investments are held by the community. Historical data. I think as the conversation expands, somehow examples, both of what you experienced in these previous waivers, and examples of how this might be done. Like, for example, by mentioning the regional equity coalitions. Well, that's interesting. That's very interesting. I think it will bring, some of these concepts to life. So getting to examples, both of the problems and of potential solutions. I got to admit, when I see the term consumer protections, and I understand the frustrations around widgets, but you know, it's important to count some widgets. And you know, what I would wish you would think about is counting the widgets that harm people. You know, we're at 900,000 opioid deaths. Those opioid prescriptions were countable, and we missed them. We missed them for 20 years. You know, I go back to the waste report that we saw some months ago. I think it'll still be important, especially from a consumer protection point of view, to watch out for the widgets that are harming people, and be more aggressive about that. I think we're still doing a mediocre job, as far as I'm concerned, about the healthcare acquired infections. And in COVID now, you can see how maybe we weren't really very well prepared from an infection control point of view to do some of that. So I think you're continuing to make progress and making people think, and looking forward to the next stage.
Thanks, John. Just two comments to follow up. One, on the historical data, again, we're not going to, there's always going to be a place where we need to take a step back and we need to evaluate what we're paying Ccos, and we need to rebase it. So I think it's the question of what's longer than a year, and probably shorter than 10. I mean, so where's the confidence level? We could set a budget for a while. We feel pretty comfortable, and that we aren't going to go awry, and we aren't going to have, and we aren't going to, and that we're taking a look at overall trends and changes and treatments and all of that, as will always happen. I think the historical piece that Laura and I've been talking a little bit about is, we've now have an ACA population and a fairly stable population with Medicaid since 2014. And do we have enough data there to say we don't need to just look at what was spent last year? Maybe we can look at what was spent kind of on average over a longer course of time, and that gives us a basis to say, this per member month should be, and that's enough to cover all of the healthcare services that are necessary. And we feel confident we can pay that for a while and stay within that and have it grow at a fixed rate of growth. And that should cover all the needed healthcare services and feel more like a budget, so that, again, those dollars are sort of shifted to other places within the system that really focus on prevention. There was another, and then the second piece around kind of counting stuff. Again, there's always going to be a place where we're going to need to count things, and I think we're trying to think through what do we need to be paying attention to make sure people are actually getting the services they need still. Again, we're coming about this from the idea that we spend almost 20% as a country of gross domestic product within the healthcare system, twice as much as any other country. So it's sort of broadly feels like there's enough money within the system for people to be able to get the care that they need. So that's kind of the presumption, but we still want to make sure that we need to be tracking access. We need to be tracking quality. So I think there's what do we need to be tracking on a member basis? And then I think there's still, what would be more system-wide? If our global budget experiment here was successful, ideally, the system should be promoting higher value care, lower value care, and low value care and waste should be going away. So there's some things like that we should build in, and that really help us monitor are things going in the right direction or
not. Brenda, you had a follow-up question?
Yeah, thank you. And it's I think in navigating the change, so it's kind of in the spirit of that conversation where both, as we're listening and planning and putting the mechanisms together for the application itself, I'm thinking about communicating the transition from the current state to the future state, specifically in the territory of accountability. So as I hear the theme around putting more both flexibility, resource and accountability into community and into the system, and the Ccos having more decision-making levers and control over some of the way the healthcare spend actually works. We know the state also holds itself, ultimately accountable for the health of all Oregonians. And so I'm thinking about how do we communicate where communities actually have like 100% accountability on a particular body of work, or where both what John was saying, or I think your response, Jeremy, where we really want to monitor the things that are on a watch list, in essence, that if it moves within a certain range of something, we have, now the state intervenes. And I think trying to get at how explicit in the process we can be with the state's role while also recognizing the power of community decision making. So I can think of scenarios where in community, the resource allocation may go in such a way that the state actually has a problem with it, right? And so how do we mitigate against those sorts of interactions so that our pendulum doesn't swing one way too far or the other? So mostly a comment and something I know I'll be on the watch for, you know, and hopefully there's a strategy by which we describe that motion and that movement into community through this waiver itself. Yeah.
And Brendan, just on the timeline, just to be clear, so we are, you know, even if we got everything we wanted, you know, design this model, CMS totally signed off on it. I mean, we're years away. We're thinking this is probably not fully implemented until the next 5-year CCO contract, just giving timing, because our waiver will be approved hopefully middle of 2022. At that point, rates will already have been established for 2023, and there's only 1 year left in the CCO contract after that. So it'll be a phase in, I think, up to the next CCO contract.
I have a question about, you know, one of the goals with the waiver is to cover all people, and we have some legislation going through, or at least in the process, that is meant to expand coverage. So I was wondering if you could sort of talk to like how those two are parallel to each other or align with each other, or how they differ. I just would love to kind of get a little bit of perspective around that.
Yeah, so you know, we're still working through this, but I mean, part of our overall message to the federal government is that we are stated as establishing a cost growth. You know, underneath our broad umbrella of equity, we've got two key goals within that of having a higher value system that's lower cost and sustainable, and that we also expand coverage and get to a spot as close as we can to universal coverage as a state. And one of the things we've done as a state is the work around Senate Bill 889 and setting a statewide cost growth target that if we're successful, will save the federal government a lot of money. And in the process, we would like to be able to leverage some of those savings to be able to both put in places where we can address some inequities, and part of that could be some of the coverage pieces. There's other ways we might be able to get there outside of shared savings, you know, and how we leverage some federal dollars, things within the marketplace. So I think it's broader than Medicaid or cover all people. Necessarily, it's a broader conversation with them. How do we really stitch together a number of things? But I think overall message that we'll be taking is, you know, we're really as a state making a huge effort to contain costs of the entire healthcare system, in part so that we can make sure everybody has access to it, and so help us achieve, you know, that goal.
Thank you. Any other questions from board members? All right, well, thank you so much, Jeremy and Lori, for your presentation. Really appreciate all the work that you're doing to move this forward.
Thank you.
Great, thanks.
Okay, we are moving into the final agenda item, and we have Dr. Santa, who is our board liaison to the Metrics and Scoring Committee and the Health Plan Quality Metrics Committee. And he would like to discuss an early childhood social emotional metric that is under consideration by these two committees. We held an educational webinar last week for board members, staff, and the public to learn more about this metric, knowing that we would be talking about it today. You know, there was a link in your board materials to the webinar, so hopefully you all had a chance to view that. And I'm going to turn it over to John, who is going to give us a little bit of some context and discussion for this.
Thanks, Oscar. No slides, no formal presentation. I see Colin Ruland and Elena Rivera have come on, and after I finish my comments, they'll be available to answer questions from board members. So I'm bringing to the attention of the board the next round of decision making related to the children's social and emotional health metric. This is coming in the third year of a six-year project involving a unique collaboration of state community groups and measurement experts focused on kindergarten readiness. This year is crucial. The project seeks to add a third measure involving children to the incentive metric set in 2022. Now realize there's already two incentive metrics having to do with children. Well visits for children, physical health, and preventive dental visits, dental health. From the outset, this third measure focused on the social and emotional health of children has been seen as a key step in integration of physical, dental, and mental health. You know, as I listened to the previous presentations, so many bullet points were mentioned that in many respects, this project is just a bullseye. OHPB has had multiple presentations about this project in the past and expressed admiration and support for it. And it's been presented in multiple venues with support at every step. This is transformative work that's been recognized nationally and funded by philanthropies. Where are we at with this? The metric was recently presented to HPQMC, and a motion to put the metric on the menu of possible incentive measures, making it possible for metrics and scoring to deliberate on it, was approved unanimously. During that discussion, there were concerns expressed about the impact of COVID on CCOs and the many tasks that CCO staff and clinicians are involved in. It was pointed out that the evidence is strong that young children have been very affected by the epidemic from a social and emotional point of view and are likely as in need of this type of activity as ever, if not more. Now, OHPB played a significant role 3 years ago in urging that developmental measures like this one go forward. I'm sure many of you recall the challenges the equity interpreter measure faced and the actions, and we took actions to actively express our support for it. We also briefly discussed back in September the failure of the weight loss measure to move through the metrics and scoring process. The development of this metric has involved hundreds of people over multiple years, many opportunities for input. 11 CCOs have piloted the measure since February, and staff involved in that pilot have expressed readiness to move forward, and Elena and Colleen can describe that further. I ask that we indicate our support for this project and this measure. On November 7th, 2017, OHPB met at the Astoria City Hall. We heard a presentation from the Astoria School District there. They presented stunning statistics from a study they had done of kindergartners in terms of the social emotional challenges they reported. Parents incarcerated, abuse, guns in the home, food insecurity. The anecdote that I remember most was that there were now so many school children living in the Fort Stevens campground that a specific bus had to go out there and pick them all up. 3.5 years later, we're on the verge of moving forward with what could be a solution. And I hope the policy board will join so many others in supporting this project and move it forward. Thank you.
Thank you, John. Since Elena and Colleen are here, I thought it might be nice to actually allow them to introduce themselves. They facilitated the webinar and give them an opportunity to also make some comments. Let's go ahead and start with Colleen.
Sure. Hi, my name is Colleen Ruland. I'm the director of the Oregon Pediatric Improvement Partnership. We do population-based improvement work for children across the state. And this metric really builds off work we've done over the last decade and intentionally in different types of communities in the state to learn from them. And then my partner in crime on this work is Elena, who I'll let her introduce herself. I do want to note just the really important partnership also with the Oregon Health Authority. This work has been a collaborative effort with the Oregon Health Authority led by Dana Harganani, and in partnership with Health Analytics, with the Child Behavioral Health team, and with the policy team. So I want to acknowledge them as really important partners in the work. Elena, do you want to introduce yourself?
Yeah, hi everyone. Thank you so much for the opportunity to elevate this to your table. So my name is Elena Rivera. I'm the Senior Health Policy Advisor at Children's Institute. We're a statewide nonprofit advocacy organization. We advocate for early investments and policy and systems change to support all children to thrive. And so for Children's Institute, we've been working for 15 years, really focused on the kinds of programs, supports, and services that help children to be ready for kindergarten, acknowledging that kindergarten readiness is one of the earliest predictors we have of just lifelong health and well-being for Oregonians.
And then the only other thing I'll add, John mentioned that health plan quality metrics and metrics and scoring, I think it's the first time they endorsed a multi-phase strategy of 4 different measures over 4 years. As you guys know, when we hit transformational measures, you're going to need people to lean in and develop those measures. They're going to need to go get fundraising. They're going to need to do in Portland piloting work that's going to have to meet all the measurement criteria that health plan quality metrics has. I sit on that committee, and that metrics and scoring has. And so that work, and when John kind of noted the 6 years of work, that is what it takes to develop these hard new measures that I hear you asking for and prioritizing the committees to look for. And so I'm thankful that we had some of the private foundations to fund that work and some of the partnerships in place. I will say though, when we did, under the direction of metrics and scoring, who asked us to facilitate the health aspects of kindergarten readiness work group, while there were 4 measures that ended up being part of that proposal, and we have the relative rank score of those measures in terms of how well they met the criteria, from the first meeting to the last meeting, the top priority topic raised by providers, early learning, parent, health systems was social emotional. That if children show up at kindergarten unable to self-regulate, and children that appear in certain ways can actually get differentially treated from the get-go in kindergarten. And that becomes a social determinant of health in that they are labeled, categorized, and treated quite differently in school if they can't self-regulate. And so there was a lot around the root cause reasons why we have social emotional delays. So I would say of the 4, this was also the one that the committee pretty clearly articulated was the most important. There just wasn't a metric available for us to recommend for adoption in 2020 when the measurement set was set forth in terms of the strategy.
And I recall from the webinar last week that there was a very specific request from the presenters coming to the board. And I just want to make sure we give you the opportunity to make that request so that we can discuss that.
Do you want me to do that, Elena, or you?
Sure, go on ahead.
As a member of health plan quality metrics, when we look at our priority measures, one of the things we're asked to look at is this aligned with the state priorities? And they list you, the Oregon Health Policy Board member, priorities as one of the places we're supposed to look. When you look at metrics and scoring and the criteria that they use, and as they're now currently developing criteria around transformational measures, they too have noted the importance of thinking about the lever of metrics and scoring to align with your priorities, but also to think about the lever of metrics and scoring to ensure that we're thinking about upstream activities and to think through alignment with priorities. And so part of the reason that I've heard them negotiate and debate how well this metric aligns with priority areas was that it would be helpful, if possible, to have the Oregon Health Policy Board weigh in on your thoughts around the measure, because I have seen them note that in the past. John mentioned the equity measure and other measures, that when those kind of strong statements of support were made, I saw that used as an opportunity within metrics and scoring, given they're in a very tough position to determine a very tough number of metrics. And so I see them put that on a pro column or potentially a negative column when they're weighing a metric.
Thank you so much. With that, I'll go ahead and open it up for board discussion. Do folks have questions or comments at this point? Brenda.
Thanks. I had the great privilege of watching the webinar, so thank you all for that. Both the deep dive and how you described the work, this incredible body of work that happened prior to today's conversation, and what it takes in terms of perseverance and discipline to hang in there despite the kinds of resistance that we know these transformational measures really cause systems to respond to. Or, sometimes I think we respond really well to them, and other times I think we notice that things kind of languish in both their decision making and in their implementation because we don't necessarily understand the implications of them. So with that background, I'm wondering if you can speak a little bit to the resistance that you already anticipate, both that you felt, and in these pilot kind of periods, and what you would recognize that metrics and scoring or health plan quality metrics, that they are also contemplating. If you could share a little bit more about those pinch points, that would be helpful. Thanks.
You want me to go first or you go first?
You kick off and I'll chime in.
Okay, all right. I'm gonna start first with the CCO, the 11 CCO pilots, which the ones in your region participated. And then, but I'm gonna actually expand to the proof pilot work because that's the kind of component. So I think our opportunity, the value of an incentive measure pool is they shouldn't be for things that aren't hard, right? Like if we're going to tie hundreds and thousands of dollars to something, they should be something that is not currently happening. So I think the opportunity with this metric is, I think there's like a good awareness generally around adverse childhood events and kind of what that impact of the first 5 years of life is. I think really kind of operationalizing how you do an intentional focus, like how you operationalize a focus on a social determinant of health, and how do you think through the various roles within the cross-sector systems is the intentional purpose of this measure. Because you can't actually get to addressing social emotional health by just telling a primary care practice to screen, or telling behavioral health provider to have this, or telling early learning providers to identify children. It's going to require a cross-sector focus. And I think we're at this great time in that because we've had an investment since the beginning of CCOs, and investment since the beginning of the early learning division on that cross-sector focus. So I think we have some good groundwork, but this is going to require some new work to happen beyond that part. And so that was some of the compromise we made in the measure. So as you saw in the measure, we're allowing for a glide path that, particularly because we're recognizing the impacts of the pandemic, that actually kind of has them leverage off the strengths that they have. So All Care in your region has amazing strengths in this area, but these are new things that we're going to be asking that would build off that. So some of the new work is thinking through how do you, in years 1 and 2, really think about those relationships, but operationalize specific focuses, and how do we think about community level factors? Because how Yamhill is going to do it is different than how Eastern Oregon is going to do it, and different than how Portland's going to do it. And that's hard because I think for some of the other measures, it's been like, well visits. This is the claim, do it. And there's a very prescriptive answer. And so we had to strike the balance of standardization. We had to strike the balance of what are the most important things informed by the thousands of people and the proof pilots, with also allowing for that community level, community driven conversation. And so that's part of the, not the sacrifice, but that's part of the staggered approach that we went through, that for some of us, we want to get to that year 4, but we have to recognize where the systems are. We have to recognize the value of the transformational funds to support that work. And we also have to recognize that we're in the midst of a pandemic. So what are the important pieces that we can do in terms of laying the groundwork now, given that we haven't seen any growth or improvement since 2016 when we look at it for these children. So I think that part is going to feel new in terms of not just having conversations with cross-sector partners, but actually thinking about how do you operationalize components. I'm proud of the strategy we use to stagger that, to allow for those conversations and to ensure feasibility. I think our intentional focus on historically marginalized populations has thrown some of the CCOs of like, you don't want me to just improve the measure overall. Right now in our measurement program, I mean, John, I'll give the well visit example. There's no incentive to think about the most vulnerable children that should be getting well visits. It's the incentive now is to go with the most. So you go to the biggest cities, you go to the most white dominant populations, and that's not bad. I mean, they're not bad people or bad systems, right? That's just what we're doing. So this intentional focus to actually say, we want to raise the bar for all children, but we got to raise the bar for those children who have experiences that are aligned with adverse childhood events, for whom we know when they show up to school, they will experience things differently. That's a new part. And again, I'm really thankful that we're not just using words in the measure, we're actually giving them actionable tools, actionable data, and giving them time to design that action plan before going to requiring new clinical processes in year one during a pandemic. So I think that's the second thing we've heard. And then I just think the third overall thing we've heard is asking to do more in a COVID response, which again is part of the reason we came up with this staggered approach. And part of the reason, for example, one component is like looking at your behavioral health providers and your patient-centered primary care homes and your early learning. We know that primary care homes are in a really tricky situation right now. So that's not a component of year one in 2022, partially because we recognize that kind of like focus on vaccine. I will say that's exactly why I think it needs to be a metric, because I don't think anybody's not going to think about COVID in the next year. We're all going to be thinking about COVID, and in myopically thinking about COVID and COVID response, we should probably be really clear, there has not been a focus on children in a year of their life, 2 years of their life, 3 years of their life is a big deal. So those are the four biggest that I think are kind of new. And then just with, I guess the last one would be, we're actually asking them to look at a population. So none of the CCOs, for example, had ever looked at how many, so they get a global budget. You guys just talked about global budget. And they have to assure services. You guys just talked about that. In the pilot, nobody had actually looked at, of children, how many have accessed services across the continuum of social, emotional, and behavioral health. So this kind of knowledge of this population that you had a global budget for, how many are actually accessing those services, that hadn't been done before. So the measure we're giving is novel. So anytime something's novel, that's gonna be hard to look at. So I think that's gonna feel new. It's gonna feel new to say, you want me to look at the access of services at a behavioral health level, and you want me to look at it for these young children. And again, it's why the first year is really anchored to actually doing that work of looking at it, facilitating conversations. That's why the first year of work isn't anchored to figuring out directly in that first year, that kind of outcome-based measure, which they're used to in terms of the incentive metric set.
Yeah, the only thing I would add is, one thing we heard loud and clear from CCOs is that they have a lot of other requirements to really be moving forward the goals of health system transformation and a focus on social determinants of health. And so CCOs talked to us about their requirements around making investments in social determinants of health, building cross-sector partnerships, doing equity-focused consumer engagement, building out more and deepening integrated behavioral health. And so one real intentional step that we took as a team was to think about how to align with those requirements. So how could our requirements around partnering with cross-sector organizations to have this focus on social emotional health? We thought about, okay, what cross-sector partnerships are CCOs already required to have? And how could this conversation take place in the context of meetings that CCOs are already convening with community advisory councils or advocacy groups? How could we leverage the work that CCOs are doing around integrated behavioral health but for this explicit focus on young children. So we thought really quite a bit about how to leverage and build on other requirements that CCOs have to really lessen the burden and acknowledge that a lot of that foundational work has already happened and is a great asset.
Kirsten, do you have any comments or questions?
No, I mean, I'm excited about the metric. It sounds great. It seems like it aligns with several of our priority areas in different ways, it touches on them. And I'm a big fan of transformational metrics and seeing our state stretch. And I think we're going to have to stretch to meet our health equity goals of 2030. And sometimes that will be easier than other times. Sometimes it's not going to be. So I like this for those reasons. I guess it might be helpful for me. You talked about in the past, OHPB has supported transformational metrics. It would be helpful if you talked about like I guess maybe OHA staff want to answer this too, but how exactly did the board support those, and especially at this stage in the process?
I can try to take a stab at it. I think that was directly to Colleen, so I'm not calling you a specific example, but I'm not aware that I'm not aware that the board has sort of endorsed a specific measure here or there. Maybe they have, and the staff can chime in if I'm not remember them. I remember specifically that, the area where the board felt pretty strongly is feeling like they really needed to lean in and provide specific direction to HPQ and CM metrics and scoring around adopting an equity metric. And that's a conversation the board had for a long time and felt like they were moving in that direction. But I don't recall a time, but maybe Steph remembers, where a metric sort of was developed and came back to the board for endorsement.
John, you can weigh in, John.
Yeah, Oscar, we did over a 2-year period go back and forth around the equity measure. And in one case, we did write a letter. I'm not asking that we do that here. And Troby and I took it to HPQMC, and Colleen probably remembers that. And I'll be honest with you, last summer when the weight loss measure came before metrics and scoring, we had not had any conversation at OHPB about it. And, I felt somewhat helpless as it, was not deliberated on. And that's one of the reasons why I feel so strongly about this one. And this time I don't want to feel helpless if there are concerns expressed there.
Thank you, John. And I just noticed, Ebony, welcome back. I wasn't sure if you were still listening in or if you got cut off due to internet issues.
At some point I got caught off, but I have a lot of thoughts and excitement around this metric, but I can wait to share.
Sure, we'll give you a minute to sort of come back and get settled. I think for me, in terms of my thoughts and comments around this, one of the things that I've been thinking a lot about is just, the pandemic and the kind of trauma it's actually causing with families, particularly low-income families, BIPOC families, who are most disproportionately being impacted by the results of the pandemic. The stress that is happening with adults that is then transferred to children. A lot of the conversations that we've been having have been about how do we build back something better and something different, and how do we create something that is stronger and better than what we've been used to. And to me, this seems like one of those ways to be able to achieve that and do something that is going to help us build a better system. And I know how tough it is to sort of feel like there's more restrictions or more expectations being added during the pandemic, but I also know these are really, really important because I just can't even imagine the type of trauma and stress that's happening right now with families and particularly children. I want to check back in with other board members who may have other comments or thoughts regarding the metric.
The one thing that I was just going to say is that, you know, we continue to be in the pandemic. We continue to put a lot of our energy, focus, resource around, you know, the COVID-19 response. And at the same time, you know, I think as been highlighted and mentioned is that there are other areas such as this metric that we need to continue to look at and move forward, because we are seeing some of the concerns, disparities play out now, even at a more elevated rate. Thus, while it can seem and feel overwhelming, or like, is this the right time to be trying to make this adjustment or change or move this forward in light of the pandemic, you know, I think it's the right thing to do. And, you know, last week's or the webinar on this, you know, it took me back to, you know, when we were doing the metrics specific to, I think, the DHS mental health assessment, and just, you know, the anxiety, but we were able to achieve it and exceed and sustain. And so glad that this is moving forward, and I appreciate the thought and discussion and intention.
Thank you, Ebony. Brenda, I think I saw you raise your hand.
Oh, I love how we echo one another, you know, in this board. I support the notion wholeheartedly, and I think about it in the context of, as Ebony and Oscar, you both alluded to, this is a component of our COVID response, you know, and there is no better time, you know, and if we had done this years ago, what might have our COVID response actually look like? You know, if we were tending to the social and emotional needs of kids and families in a different kind of a way where we weren't as distracted perhaps. And while it's easy to kind of go back historically and pontificate about that, there is no better time than to use the momentum, quite honestly, to fuel transformational behavior. And I would also just suggest that systems are now better positioned to respond collaboratively than perhaps we had in the past. This is like one of the silver linings of COVID, where education and healthcare are coming together to respond to community demands in ways and conversations and at different tables than were set previously. So with that, I'll just pause. I know others are fans of this as well. Thank you, John, for bringing it to us. You know, if I know we're kind of right on the cusp of potentially a formal board action, but at least from my perspective, I would say directionally dead on. That would be my feedback for today. Thanks.
Thank you, Brenda. Kirsten, go ahead.
I don't want to distract this conversation, so I'm very interested in this metric and want to make sure that we follow that conversation through. But in this process, I did want to underscore my support for a kind of bigger perspective that Colleen raised around metrics being used to that if they're easily attainable, they're not the right metric. That we shouldn't be paying for something that is done or incentivizing things that are done anyway. And I just that is a frame that really speaks a lot to my volumes and to the like lens that I like to review these. Not, you know, there's lots of metrics and not just HPQMC, but all sorts of places in healthcare in our lives. And I don't know whether, John, it sounded like you were looking for some kind of robust backing almost in your liaison role, or I don't know how you would describe that, but I guess I would say, like, not only do I feel, or I would like to propose that, like, yeah, you know, sounds like we have support for this metric, please go with backing on that. But also, I guess I would like to add kind of this additional nuance of like generally a lens looking for metrics that really help us grow and push.
Well, you know, what I feel like is I just want to be comfortable communicating that, as Colleen mentioned earlier, I think Colleen and Elena came because they want us to say that they are aligned, that the project and the metric is aligned in terms of our priorities, and that we support it. Again, metrics and scoring, we talked about it at our retreat. They have this unique status of being the decision maker. They are the decision maker. We are not making this decision. But that doesn't mean we can't communicate to them that we support the project and metric and it is aligned with our priorities. And you know, going beyond that in terms of developmental, the other developmental metrics, I mean, I've always thought that this one was the example of how to do it, you know, and in part because Dana and Colleen and Elena have done such a fantastic job of getting resources to do it. I'm not quite sure what to say about the future of developmental metrics based on this, but I think it would be great if we were comfortable with support and confirming alignment.
I want to also mention that even though Dr. Banksberg is not here, he had a chance to weigh in during our leadership meetings before, and he was also supportive of this effort. So I just want to make sure that he has also been supportive of this as well. I think this aligns, personally, I think this aligns to a lot of the work that we've been doing, you know, our priorities to support our committees and the work that's happening within our committees. Also, you know, it sounds like there's going to be a pretty robust community engagement, particularly within communities of color, some oversight as well and guidance regarding spending decisions, which is all important. I feel it connects to our waiver priorities. So I want to make sure that, John, when you're back at Metrics and Scoring, you at least have my support. I'll check in with other board members and kind of close out with their statements. Let's go ahead and start with Brenda.
Oh, I have nothing else to add. I appreciate the thoughtfulness. I think the emphasis on the background work was really powerful. You know, that this is not a new topic for the systems to engage. I think the specific focus on BIPOC communities is critical. And I also deeply appreciate the staging. You know, it is COVID responsive and recognizing systems are still in the midst of really heavy lifting, and that it's much more attainable to think about next year without it being quite as intense as what we might imagine year 4. And I appreciate that that pace was very thoughtfully designed. So with all that background, I'm in support of the direction. Thank you.
Thank you, Brenda. Kirsten.
Likewise.
Okay, Ebony.
The only other thing I'll just add is, you know, I always like to look at and think about, you know, how are we strategically assuring continuity with kind of key priorities. And, you know, I just also think that there's a strong connection to, you know, thinking upstream. And, you know, obviously the more that we and the sooner we can get to our, to the children and to the early childhood population, you know, that is super upstream. And so not only are we going to impact costs, but we are impacting and improving lives. And that's what's most important. And then again, with this priority around, you know, what I like to call leading with race. And, you know, with some of the work that we're doing around looking at racism as a public health crisis, at least locally in Multnomah County, you know, I think that this really fits in, especially when you think about the BIPOC lens too. So Thank you.
Thank you, Ebony. And John, comments?
No, this is a great discussion, and I feel that there's a support and alignment out there, and the minutes will reflect that. And I'm very satisfied with the discussion. Thank you.
Excellent. All right. Well, thank you all for participating in that discussion. It sounds like John will now be able to communicate the board's support at the next metrics and scoring committee, and it'll be reflected on the minutes from this meeting. That is all we have for our agenda. We're going to get to wrap up a few minutes early, so that's exciting as well. And Chair Bangsberg will be back next month to continue facilitating our board meetings. I want to give just thanks to the executive OHA leadership for all their support, getting our materials and our packets and our agendas ready, and for all their support preparing me for the meeting. And thank you to my fellow policy board members for the great conversation today and the discussion. Really appreciate everybody's dedication and passion towards this effort, and excited for confirmation of 2 more new board members and having them join us possibly in June. So have a wonderful day, and we'll see you all soon.